Good morning, everybody. We have a long day. I know that not every member of the committee is here, but sorry, we're starting. And we'll open the hearing on House Bill 1022. I do have the first sign-up sheet, if that's what you're looking for. I hope I left more out there. Representative Blazek, are you here to introduce? Good morning. And after Representative Blazek, I'm going to recognize Dr. Phelan, and then Representative Blazek has somebody that you want to testify right after that. So with apologies to other reps that are here, that's the order. Go ahead.
Thank you, Mr. Chair, members of the committee. For the record, I am Representative Melissa Blazek, and I represent Hillsborough 21, the town of Merrimack. I am here today to introduce HB 1022. Passing this bill would allow New Hampshire to join Tennessee in being the second state to make ivermectin available without an individual prescription. Representative Leah Cushman wrote this for me, but I got a couple thoughts at the end. But ivermectin is a Nobel Peace Prize winning drug that has been registered for human use since 1987 and 1988. A massive campaign was implemented in Africa to combat river blindness. Ivermectin was shown over the next 33 years to be extremely effective and well tolerated. It has been shown to be useful in treatment of. It has demonstrated inhibitory effects against HIV, at least 2 dengue fever viruses, influenza, simian virus, SV40, and a number of others. Ivermectin is safe. It has been administered to humans globally for more than 30 years, with an estimated more than 3.4 billion doses given with very few adverse effects. Davis's drug guide lists more adverse effects in severity and number from Tylenol than from ivermectin. It is available over the counter in many countries and is often administered by non-medical personnel with very little training due to its safe drug profile. At least 60 controlled studies and 32 randomized controlled studies have shown that it improved outcomes in mortality, ventilation, viral clearance, and case reduction. Over 20 countries have adopted ivermectin for treatment against COVID-19. Multiple meta-analyses have shown that ivermectin helps in all stages of illness, but it is most effective when it is started soon after symptom onset or as a prophylactic after exposure. In the Indian state of Uttar Pradesh, my husband's from there, he says I say it wrong, I'm sure many of you are aware, has managed to keep cases low and prevented overwhelm of its medical system due to the widespread use of ivermectin as prophylaxis and early treatment. Knowing that it is safe and that many studies are showing its benefit, and knowing that it's used in other countries as a first-line treatment, why would we restrict access to this medication? There have been efforts to categorize this off-label treatment and other repurposed drugs as dangerous and not recommended. Although the bureaucratic organizations of government and professional authorities rage against it, ask doctors and nurses what they think, and many have a different professional opinion. They've looked at the evidence and they see the opportunity to help people. Unfortunately, the campaign to demonize this out-of-patent drug as dangerous horse paste has had a chilling effect on the medical community's willingness to utilize it. Most doctors work for large hospital systems which have policies that forbid treating with ivermectin, and so they can't prescribe it even if they want to. How far the practice of medicine has fallen when doctors cannot use their knowledge of medications and physiology and repurpose drugs to help people improve their health. More than 20% of prescriptions given are for off-label use. Oral contraceptives, which are available at pharmacies via a standing order, are used for a variety of off-label indications such as menstrual irregularity and acne. Oral contraceptives carry significant risk, including decreased glucose tolerance, increased blood pressure, bleeding irregularities, and blood clots. Over 60% of women who discontinue use of oral contraceptives report doing so due to adverse effects. Many of the same groups lobbying for the bill that made oral contraceptives available over the counter are lobbying against this bill, even though ivermectin is safer than oral contraceptives. This is a glaring example of the politicization of medicine. Our hospital systems, which lobby against this bill, strongly advocate for vaccination with vaccines that have had the highest number of reported adverse events events of all vaccines in the last 40 years combined, with known safety issues and low efficacy that wanes within months and no long-term safety studies. Not only do they lobby for vaccination, they've implemented vaccine mandates. They offer emergency use authorized treatments such as remdesivir, which also have not been studied long-term and carry a high risk of kidney damage and poor success rate. They're beginning to offer recently EUA authorized Paxlovid, which has no long-term safety studies and utilizes only one mechanism of action against COVID. Ivermectin, on the other hand, has been used safely for decades and has more than 10 documented mechanisms of action that inhibit COVID-19's ability to make people very sick. The hospitals advocate that people stay home until they have complications such as blood clots or hypoxia, offering no early treatment. Then with the staff shortages from morale distress and vaccine mandates leading to fewer open beds combined with rising cases and no early treatment, susceptible patients fill up the few available ICU beds and bring the hospital system close to collapse, as we saw this winter. If there is a safe drug available that could help reduce the burden on the hospital systems and save lives, why would the hospitals and professional organizations rally against it like no repurposed drug in history? Ivermectin is inexpensive. It can be compounded locally. It has been out of patent for years, and it is not a money-making drug. It is demonstrably safe and increasingly proven effective. The NIH COVID-19 treatment guidelines panel changed its guidelines on ivermectin from recommending against its use to stating that it, quote, has insufficient data to recommend either for or against the use of ivermectin for the treatment of COVID-19. That is the most positive recommendation they can give because they do not make recommendations for drugs for off-label indications as a matter of policy. Are more studies needed? Yes, larger studies are needed, but researchers have already used meta-analyses to combine smaller studies and make sense of the data as a whole, and multiple meta-analyses have shown positive effects from ivermectin. Standing orders are specific and can be written essentially in algorithmic form for dosage instructions based on patient weight and indication. They could be written according to the FLCCC protocol, which was created by frontline critical care providers that have been studying treatment effectiveness for COVID patients since the beginning of the pandemic. Not all pharmacies, especially large corporate pharmacies and hospital pharmacies, will be willing to take standing orders for ivermectin, but some will. Not all doctors will be willing to risk persecution and potential disciplinary action for writing a standing order, but some brave souls will. Even if one pharmacy receives a standing order from one physician in New Hampshire, it would be better than none. And I just have my own thoughts real briefly, but I understand that this bill is a very big step. But the reality is that people who want this drug will get it regardless. Do we want them getting it from an overseas pharmacy where the quality and purity can't be guaranteed, or worse, by veterinarian grade? Or do we want them to buy a reliably safe product? Narcan and oral contraceptives are already available via a standing order in New Hampshire. Considering that this is the live free or die state and not the nanny state, perhaps we need to continue evaluating drugs with excellent safety profiles and adding them to this list. People should have the right to make these decisions for themselves if the drug is that safe. And finally, this bill is a bill of choice and freedom. Let's empower the individual to take charge of their health and make this drug easily accessible to those individuals and the doctors who help treat them. Thank you.
One question, Senator Sherman.
Thank you. Thank you for your testimony. You mentioned that there are multiple studies that show the drug's efficacy.
Yes.
And the major study written by Hill actually was retracted because it had fraudulent data in it. In the last two journal articles, most recently in the New England Journal, have shown no statistical benefit from ivermectin. Would you please provide those studies that you said? I mean, can you just provide the committee with a list of the studies that show its efficacy?
Sure, there are over 60. There are actually far more that outweigh some of those ones.
Thank you.
And we do have a person here who will go through all of those studies with you.
I just have one question. It's my view, and I want to know if it's your view, that if House Bill 1466 passes,
Sure.
Which is broader than just this bill, which
Of course,
is
it's all off-label.
will that also allow prescribers to prescribe ivermectin?
Oh, of course. Now, I want to be clear. There is no law that prohibits a doctor currently from prescribing ivermectin. However, there have been a lot of threatening letters been sent out from medical boards against treating COVID with off-label indications. And so many doctors are too afraid. And yes, 1466, I think, would give doctors more confidence that they can prescribe ivermectin, but it is a better safety profile than Tylenol, and I don't see why we can't empower the individual. And it doesn't have to just be used for, I mean, ivermectin is a broad range of uses. Obviously, we know it very well as an anti-parasitic. If somebody gets a parasite, it's such a safe drug, I don't see why they can't go down to the pharmacy and get a prescription or get ivermectin easily.
Okay, thank you very much.
Thank you.
I'll recognize now Dr. Krupp, and then followed by Joan Chamey. Is it Joan or Juan? Sorry about that. Man, I need much stronger prescription here. Doctor, good morning.
Good morning. Thank you, Mr. Chairman, for the opportunity. I'm Eric Kropp. I'm a family physician practicing in Concord and speaking for the New Hampshire Medical Society as well. This bill, we are in opposition to this. This amounts to a limited scope practice of medicine by pharmacists, which we've have two laws already on the books for this. One is for nicotine cessation therapy. One is for the prescription of dispensing of hormonal contraceptives. This bill tries to put ivermectin in the same category as those, but it's very different. Those medications have decades of history of consistent use, safety, efficacy, deep knowledge of the limitations and the risks associated with those. And the laws around those also mandate standardized education programs for those pharmacists that will be prescribing those, standard protocols that are constructed along with the consent of the Board of Medicine, the Board of Nursing, and the Department of HHS in order to develop those protocols. So the use of ivermectin in this case is not well established, is not FDA approved. The research is constantly changing. The disease itself is constantly changing. There was a lot of early research that suggested some improvement. Dr. Sherman, you mentioned the retraction of one of the largest studies. The two most recent studies in the New England Journal of Medicine and JAMA both failed to show an improvement. So this is a rapidly changing landscape without the type of standard knowledge, understanding, and practices in order to put something like this into the law. And we hope that you'll find it inexpedient to legislate.
Are there questions of Dr. Krupp? I'll ask the same question I just asked of Representative Blazek. The bill that was introduced, House Bill 1466, relative to off-label prescribing, which, as she noted correctly, is intended to give prescribers more confidence in prescribing off-label prescriptions. In your opinion, does that cover a prescriber that wanted to prescribe ivermectin for COVID?
Yes, that would.
And your answer is yes, it does?
Yes.
Okay,
Yes.
thank you very much. Seeing, set one question.
Real quick, as I read the bill, it says this bill allows pharmacies to dispense, and one of your earlier statements was this limits practice. I'm not sure how I don't follow. If this is allowing them, how is this limiting the practice?
I'm sorry. The practice of pharmacists prescribing nicotine cessation therapy and hormonal contraceptives, I would categorize that as a limited practice of medicine, meaning practicing medicine by assessing a patient, diagnosing a condition, determining the appropriateness for treatment, and then dispensing treatment. That's a practice of medicine and a limited scope of practice. So specifically, they're doing this. They're not diagnosing any disease or condition. They are making a determination whether this is an appropriate therapy. So that was my explanation, that it is a limited scope. So this bill would provide for a limited scope of practice by pharmacists to assess a patient, determine their appropriateness, and then dispense. Did that clarify? No. Okay. Well, okay. Thanks.
Seeing no further questions, thank you very much. Now, Mr. Shamey, did I get your last name right, sir? I apologize. No, I didn't do that either. You're gonna need to prescribe something for me, and I'm not exactly sure what it is.
I've got some suggestions.
Jameson?
Good morning.
Good morning, sir.
Thank you for having me. I'm Juan Chamier. I'm a data analyst. I've been researching about COVID since the beginning of the pandemic.
Thank you.
I've written 2 or 3 studies. The first one from epidemiological point of view in Peru, and recently a study from Brazil. I'm going to focus in 3 points: the safety of ivermectin, the efficacy of ivermectin, and I'm going to talk briefly about the last big study that was against ivermectin. So the first part, safety. At least 300 million people have been treated with ivermectin and donated by Merck in more than 30 countries. The WHO recommends the use of ivermectin in children and in a program in Latin America, and it called it ivermectin as a safe and effective drug. The CDC guideline in all Middle Eastern, Asian, North African, Latin American, and Caribbean refugees should receive ivermectin before entering the United States. And about side effects, headache, dizziness, shaking or trembling, diarrhea, and other side effects are related with the diseases, with onchocerciasis and strongyloidiasis, and not with the drug ivermectin. There was a study in 2022. They test the high doses of ivermectin, and they proved that even 10 times the normal dose of ivermectin was safe for people. There is a database of adverse events in Europe, and I just took the information for ivermectin, Paxlovid, and remdesivir. There are 8 reports of ivermectin, adverse events of ivermectin. None of them are fatal events. There are in the 2 months of Paxlovid, there are 100 reported cases of adverse events and 6 deaths. And if you look at remdesivir, there are 229 cases and 136 reported deaths. Now, effectiveness, there are 157 COVID studies, 108 peer reviews, 82 comparing treatment and control groups. Removing the controversial studies, like the studies that have been retracted, removing all these studies, the effectiveness still is 83% as a prophylaxis, 63% as an early treatment, and 40% as a late treatment. The study I mentioned initially about Brazil, a peer review is published in over 200,000 people in Brazil, shows 67% reduction in hospitalization rate. Epidemiological analysis show drops in cases and deaths right after the increase of use of ivermectin. And in a 2020 international survey to doctors showed effectiveness in mild, moderate, and severe cases. I think that it's number 6 is I made a study in Peru, initially in 2020. They have programs of distribution of ivermectin in different states at different moments in time. And as you can see, every time they roll out the program, there was that drastic drop in excess deaths, not cases or just deaths. So and the next is the survey. There is a American company, Sermo. They survey doctors around the world about treatment. They did the survey in 2020, and they asked doctors for the different treatments and how they rate the drug as if it was effective or very effective, and if it was safe. And one of the best, with the best results, was ivermectin in 2020, with 60% of the doctors saying is in ICU patients is highly effective, extremely effective, or very effective. And if you can see this in the same survey, remdesivir was only 24%. The last part, the Together trial, the last trial about ivermectin, is the biggest trial and has been like all over the media. In the page number 8, you can see all the criticisms of this study. There was a blinding failure. People knew that they were treated with ivermectin or not because they had different programs. The Data and Safety Monitoring Committee is not independent. People in the committee has been they written research studies with the same people in the study. Like there's one person with 100 studies together with the main author of this ivermectin study. The primary outcome was easy to change because one of the conditions was, okay, if you go to the hospital more than 6 hours, this is considered a case, and the committee was deciding if this was a hospitalized or not patient. They also removed 77 people from the study as in the placebo group, and the data don't match. The numbers don't match. If you look in the next slide, number 8, is the primary outcome in the actual study. They show in the results that there are 211 hospitalization in total, and if you look at the tables, there are 138. So the basic primary outcome is different in 3 places in the study. And also, there are impossible numbers from the patients they removed from the study. They show that they have 9 of these people went to ICU, but only 4 went to the hospital. So it's impossible going to the ICU without going to the hospital. And that's it. I'm from Colombia. You can find ivermectin over the country in Colombia. There are programs in most of the places in Latin America that recommend taking antiparasitic drugs twice per year, from small children to adults, and it's been safe, and no one has reported any adverse events.
Question, Senator Avard, one question.
One question. Thank you, and well done. Good job. We really appreciate your testimony. Just on page 2, where it says the CDC guidelines, all Middle Eastern, Asian, North African, Latin American, and Caribbean refugees should receive presumptive therapy with ivermectin. How do I find that information as a fact?
I think at the end, in the last page.
Yeah, on page 2. It's your third point on page 2. I just want to know where is that actually found? It's CDC, but how do I find that?
It's in the last page of the document. In the number 3 is the link for the the CDC. Yeah, it's there.
I can be taught. Thank you.
Senator Sherman.
Thank you. Just follow up on Senator Avard's question. Is that CDC guideline that you cite there actually meant to be for the recommendation because those are sites in the world where parasites are endemic as opposed to having anything to do with COVID?
No, it's an
It's
old
not
measure.
related
No,
to
it's not.
COVID is my question.
I mentioned this point, trying to raise the point of the safety, not the, yeah.
Thank you.
Thank you very much, sir. And I apologize for
No problem.
muffing up your name. Okay, Representative Gorski, good morning. Followed by Representative Knirk. Followed by Representative Torreson.
Thank you, Mr. Chairman, and thank you, committee, for hearing my testimony. First of all, for the record, my name is Representative Ted Gorski. I represent Hillsborough District 6 in Bedford. I want to, first of all, say that I have some testimony from my constituent in Bedford, a doctor, that I'd like to just submit. He wanted to provide some testimony. I'm here today to support this bill. And I want to share my personal story on how ivermectin helped me. My story starts in July 2021, where I had a physical with my doctor. And I said to him, we had a proactive conversation. What would happen? What could he do for me if I contracted COVID? His first response was, well, you have to get vaccinated. I said, beside that, what can you do for me and provide to me if I get COVID? It was 20 seconds of silence. I then asked him, would you prescribe ivermectin for me or hydroxychloroquine if I get COVID? Another 20 seconds of awkward silence. I had my answer. Fast forward to November 2021. I actually contracted COVID. Now I had my answer from my doctor. In that time period, I did some proactive investigation and found out there was an organization called Frontline Doctors that does telemedicine calls. I reached out to them, had a telemedicine call, described my symptoms, and he prescribed ivermectin to me, a 5-day dose. Within 3 days, I was 100% better. And within 5 days, my COVID symptoms were eradicated. I am a believer that ivermectin helped me eradicate COVID. I am a success story sitting here today that ivermectin works. So in closing, I think we should provide any and all treatments for our citizens here in New Hampshire and let them make the choice on whether or not a medication will work for them. Thank you for your time and thank you for listening for my testimony.
Thank you, Representative. Seeing no questions.
Thank you.
Representative Knirk, followed by Representative Torreson.
Thank you very much. For the record, Jerry Knirk, Carroll County District 3, representing Madison, Tamworth, Albany, and Freedom. And I'm here to oppose the bill. It's important to realize that permitting a pharmacist to dispense a medication by standing order, as we have in place for oral contraceptives and nicotine cessation, requires a well-evaluated protocol established through a broad consensus of providers and pharmacists using the best available data. But that broad consensus does not support the use of ivermectin in COVID-19. You've heard much this morning about the widespread use of ivermectin around the world, and that's true. It's for parasites. It's true. CDC does recommend that it be given to refugees, but that's for parasites. It has nothing to do with COVID. And you've heard claims about numerous studies, over 100 studies that demonstrate that ivermectin works in treating COVID. But it's important to realize that many of those studies are really quite flawed. They sound compelling, but on further analysis, we find that many of these studies have rather marked design flaws. They're limited by either too small a sample size, key issues, non-blinding, no randomization, the use of concomitant medications and other factors that interfere with getting a good study. And even the well-designed studies still have significant limitations, such as definitive conclusions regarding the clinical efficacy of ivermectin in COVID cannot yet be reached. We just heard an anecdote. Recovery from COVID in a few days is actually the normal. That's when you just use something, it doesn't mean that it is causally making you better. It could just be coincidental. It's important to realize that this is not an issue of censorship. It's often said, well, you know, it's a matter of censorship. It's simply subjecting these studies to the same robust analysis that should be given to any study. Medication studies are particularly well able to be done as a good randomized, controlled, placebo-controlled, blinded study. Internationally recognized independent groups such as the Cochrane Collaboration, who has decades of experience analyzing and evaluating studies, have found that most of the studies in ivermectin are of low quality. Only a few are of high quality, and those studies do not support the use of ivermectin in treating COVID. You've heard about Uttar Pradesh and ivermectin. What's important to realize, that was a totally non-controlled study, and there were a lot of other factors going on. You could have made any intervention in our country in late January of 2022, and it would have, 21, and would have looked like it worked great, because that's when we're on a downslope. You've also heard about the Brazilian study of over 200,000 people. Well, actually, it's not quite. That's what they keep claiming in the paper, but actually that's the number of people living in the city. It's actually about 160,000 studies, 160,000 subjects. That still sounds great, but you got to realize, how is that study composed? How was it designed? The way that you entered the intervention group is you walked into your doctor's office and said, I'd like to use ivermectin. The controls were those in the city who did not request it. So we've already introduced a significant selection bias. And the reason for that's important is that the people who showed up in the office and asked for it, they're going to be healthcare seekers. They're people who have probably a higher socioeconomic status, better access to healthcare, probably working jobs that have less exposure to COVID. The study violated all the precepts of a good medication study. In contrast, the study published in New England Journal of Medicine last month, which was already alluded to, also done in Brazil, used the appropriate methodology of randomization of patients, placebo control, and double blinding. And that study showed no effect in preventing the progression of COVID. So this is not to say that ivermectin is not a good drug. It's a great drug if you have parasites. But we still do not have evidence that it makes a difference in COVID from well-designed studies. Hundreds of poorly designed studies are hundreds of poorly designed studies. They do not prove anything, and anecdotes do not prove anything. There is no rationale for accepting crummy studies when we have good studies. Now, the minority in HHSEA already compromised with the majority in our committee to indeed agree to HB 1466, which allows patients to be able to get ivermectin by off-label use if desired. But in that case, they have to see a provider, they have to have some proper counseling, and that is a much safer maneuver than having a standing order. So bottom line is, again, standing orders should not be used to dispense medications where it's not clearly supported by the literature and by consensus. Ivermectin doesn't reach that level. I would ask you to please ITL the bill. Thank you.
Thank you, and thank you, Mr. Chair. I appreciate your patience. Just real quickly, does ivermectin hurt people?
Actually, ivermectin does have a very good safety profile. It does have some contraindication if used with anticoagulants and a few other things. But the fact that it's a safe drug doesn't mean that it should be used just because it's safe if it doesn't have evidence it works. And part of that is because you've heard even from the previous speaker that many people equate, well, I don't need to get vaccinated because I'll go ahead and use ivermectin and that'll keep me safe. So if there's no data that it keeps you safe, you are then avoiding a proven prevention, which is vaccination, in favor of something that is not going to make a difference. That introduces harm to the patient because we're misleading them. You have to be totally honest that if you have a treatment that doesn't work, that you don't use it. I mean, remember the snake oil salesman. They would tell you all kinds of wonderful things about how it worked. But a lot of those things really didn't work, which is why we do regulate medications. The fact that it's off-label makes no difference because we use many drugs off-label. That's not a problem. But then there has to be real concern and evidence to be able to support that use as well. So yes, low risk, but that doesn't mean that it should be used because it deters people from getting appropriate treatment.
Very good.
Okay, thank you very much.
Representative, good morning.
Good morning, and thank you, Mr. Chair, and members of the committee. For the record, my name is Peter Terosian. I'm representative for the Rockingham County District 14, which is the town of Atkinson and Plastow. I'm here this morning as a co-sponsor, but also I too have a personal story to tell in regard to ivermectin. First of all, I'd like to start off by saying this drug, as you heard, has a long history of knowing what side effects it may or may not have, and the fact that even if it's not 100% for helping to treat COVID, if you get it, any side effects seems to be very minimal, if any. So this is a legislation that puts another tool in the toolbox to help fight COVID. In reality, people, even those fully vaccinated and boosted, are getting COVID. And there are some studies that indicate that there's no differentiation between those that are vaccinated versus those that are in regard to the percentage of people that are getting that. I won't debate that, but there's many people in my personal group of friends, everybody I know that's been exposed, that's been vaccinated, has gotten COVID. In the beginning of November, I got it. I'm not vaccinated. I got a fever. I had other symptoms. I believe I got the Delta variant, but I too used ivermectin within a couple of days of getting it. I believe it helped me get over it quicker than I would have otherwise. And in comparison, my son and my daughter-in-law also got COVID around the same time frame. They're fully vaccinated, fully boosted. They had worse symptoms than I did. They didn't use ivermectin. I can't sit here and say conclusively that's the reason, but I believe it certainly helped me. And so I'm not advocating that this is a replacement for getting vaccinated. That's a personal choice that everybody has to make and should make. But I believe there's minimal risks that making this drug available for those that want to have it in their toolbox to help them should they get infected. And I'll keep my remarks brief because I know you have a long day. I'm just going to go on to say that it's not 100%. And so it's not perfect, but neither are the vaccines. Because when the vaccines first came out, there was the indication that, and the statement from many involved with the production, that this was going to give you a 97%, safety against getting COVID. And we all know now that's not the case. That, again, I cited almost everybody that's vaccinated, if they're exposed to the vaccine, to the virus, seems to get it. So this is common sense legislation. Let's give the people in New Hampshire a choice, another tool in the toolbox to fight COVID should they get it. And I don't see really a downside in this. And one last thing, we know, again, there's a benchmark on this medication. When it comes to the vaccines, they're very new. We don't know. We still don't know the long-term effect of that. And I'm just pointing that out there. And I'm not suggesting that you should not get vaccinated because you think this is the cure. It's not the cure, but it's just, again, something to help you get over the symptoms and recover quicker in most cases, whether you're vaccinated or not. And with that, I'll conclude my testimony.
Thank you very much, Representative. I would now recognize Dr. Jennifer Smith, followed by Dr. York. Good morning.
Thank you, Chairman Bradley, members of the committee. I'm a retired family physician. I also have a public health degree and have done stuff in multiple foreign countries where this drug is used widely. I really object to this bill. I'm opposed to the bill on a number of levels. Number one, the legislature really is a poor place to make decisions about what is appropriate to allow. Yes, we do prescribe off-label drugs, but to make a standing order makes it really quite different, so I would oppose that. Number two is that if you allow a drug like this to be widely promoted without real good evidence, you will be diverting supplies, as happened with hydroxychloroquine, from people who would benefit. And I think that's really a mistake to be doing that. Yes, the supply chain could ramp back up with time, but it takes time. We all know about supply chain issues, I think. The third objection, and this one is really quite serious, is that the people who decide that this drug will keep me safe will present later and more likely have serious complications and maybe die. Because we do have effective things at this point, both the use of dexamethasone to suppress overreaction of the immune system and the use of some antivirals. So I think that, it's really foolish to help promote the idea that a drug that has not been proven will, in fact, be made widely available at patient decision discretion based on information that is really not right. I think Senator Sherman has it right with good studies, and Dr. Knirk, that don't show a significant useful effect. Final point, very recent meta-analysis on ivermectin says that it is not in fact proven safe in pregnancy. There have been real attempts to try to make sure that people who got it inadvertently in early pregnancy, not knowing they were pregnant, have been studied, and there is not indication at this point that it is safe. And I would remind those of you who are old enough to remember, which several of you are, that thalidomide was in widespread use in Europe, and one person at our FDA who was in a critical position said, no, we can't do this based on these studies. So we had a whole lot less birth defects from thalidomide in this country because anybody who got it because they were in Europe. Very effective drug, by the way. Still used a little bit. So I would urge you not to approve this bill. Please, if you can't just ITL this bill, maybe set up a study committee to really look more deeply into this. Thank you.
Seeing no questions, thank you very much. Dr. York. Followed by Ms. Chester. Good morning, sir.
Good morning, Mr. Chairman. Thank you. Members of the committee, thank you. I'd like to call to your attention some testimony that was recorded during the original public hearing at the House, given by Dr. Paul Merrick, a world-renowned critical care physician who gave very compelling evidence of the value of ivermectin. And the title of the email for you all is important testimony. So if you have time to review that, I think it's very valuable to get some further insight.
Can you make sure that we get it through CAMP? Thank you.
Okay, thank you. I would like to say that my world is upside down, and I'm assuming that it is upside down for a lot of people during this past couple of years. If we go back to before the pandemic started more than 2 years ago, consider the scenario of a patient and a physician in a healthcare setting whereby both patient and physician have agreed to a course of treatment for the patient via informed consent, etc. That was the norm. Now, if you fast forward to this past fall, and in a physician's office in the state of Maine, this physician was sanctioned for the simple act of prescribing a safe and effective and Nobel Prize winning drug for a treatment of ivermectin to one of her patients. This led to a loss of license and, if you can believe it, a recommendation that this physician undergo psychiatric evaluation. The world is upside down. They would have called that malpractice, but I would argue that malpractice falls on the failure of multiple government agencies, medical societies, hospitals, physicians, for the failure to come up with an early treatment protocol for COVID-19. Not much has happened in the past couple of years, and yet we face variants of COVID-19 from here to forever, it appears. So that's, for me, that's the malpractice that's happened, and I think the medical profession has failed us, unfortunately, and I say that sadly as a physician. And because my personal physician would probably not treat me for COVID-19, my family has gathered all the elements for this medical toolbox that we've assembled piecemeal, whether it be over-the-counter vitamins, natural supplements, hydroxychloroquine from telehealth, ivermectin from India, of all places. I would much prefer that my own physician would treat me, but as we have these medical supplies for all the family, extended family, my consulting physician is my spouse, who is not a physician, and vice versa. So we rely on established protocols for early treatments from alliances like the Frontline COVID Critical Care Alliance and others. So that's what we're left with. So I just would ask for your help as representatives. I don't know your party affiliation, nor does it matter to me. You're elected to represent citizens of New Hampshire, and if you're a Democrat, you're not only support Democratic constituents, you're supporting Republican constituents, and if you're a Republican senator, you're supporting all your constituents, including New Hampshire citizens. So your support of this bill will support all New Hampshire citizens with a choice, a freedom of choice in medical decisions. It will support healthcare providers to be able to provide this medicine. It will provide it will help provide pharmacists with the support that they need for their work. So please join states like Tennessee, who is this close to passing this bill. It lays on the desk of the governor to sign. That's how close it is. So although the world is upside down, I'm asking for your support to make things right again. Thank you so much.
Thank you, Doctor. Seeing no questions. Ms. Chester, followed by former Representative J.R. Holt.
Thank you, committee chair. Thank you, committee members. For the record, my name is Roseanne Chester. I'm a resident of Bedford, and I'm here to speak for the people of New Hampshire that are kind of tired of coming day after day after day and feeling like they're not being heard. Instead, the lobbyists and the large businesses seem to be having most people's ears nowadays. I've heard a lot of testimony today already about some of these things. I want to tell you two quick personal stories. One is I had a friend in 2020 who was being treated with ivermectin for cancer. Now, you probably have never heard of this. It was January of 2020. He had, because we have the right to try in our country, he paid out of pocket for the ivermectin instead of going through the typical cancer treatments. It was amazing how quickly it seemed that the ivermectin seemed to reverse the cancer. Do we know that it was? Well, it was an experimental drug. Unfortunately, what happened when our government got involved in our medicine to the point where ivermectin was a hands-off type of thing, he was no longer allowed to continue with that cancer treatment. Less than 20 days after stopping, the cancer came back. Well, it never went away, but the cancer became much more aggressive. He decided to go through, when they took the ivermectin away, he decided that he would go through the regular treatments, and he passed away in November of 2021. And it was a 5-year, he had been given 5 years to live when he was first diagnosed with the cancer and put on the ivermectin. I heard people talk today about the over-the-counter contraceptives and the over-the-counter nicotine. Bottom line is, if you look at the side effects of the over-the-counter contraceptives and the over-the-counter nicotine, those side effects are much more severe and much more of them than the side effects from ivermectin. So I just wanted to point that out. The other thing that I heard a lot about is many studies are quite flawed. We don't have enough good studies. Legislation is a poor place for this. These are the same people that have come before the House and the Senate time and time again pushing the vaccine. And the bottom line is the vaccine studies are very flawed. The vaccine studies, we don't have enough good studies. And legislation is a poor place for this. So you can't have it both ways, in my opinion. And the last point I want to drive home is just because it's safe doesn't mean it works. That is a ridiculous statement, in my opinion, because that speaks to the masking argument. Just because the masks, early on, we thought the masks didn't cause any problems. Now we're starting to see 2 years later that maybe there are some problems, maybe there aren't. We'll have to wait and see. But the bottom line is, just because it works doesn't mean just because it's safe doesn't mean it works. That's no different than taking a vitamin. Vitamins have side effects. I almost died from vitamins because I have an allergy to something. It's ridiculous that people come up here and talk against the right to try, speak against the right for us to make our own bodily autonomy choices in every aspect of our life. Give us the education we need, and we can make appropriate choices. Thank you.
Thank you, ma'am. Thank you. JR. Followed by Bruce Berkey.
Chairman, thank you. For the record, J.R. Hull, former state rep. I would like to speak in favor of this bill, House Bill 1022. We've heard discussions on efficacy a lot this morning. Does it work? Does it not? I will address that at the end. I think the primary question is one of safety. Is this a safe medication? Is this medication something that could be used with just pharmaceutical or pharmacist oversight as opposed to a full, right, the traditional the traditional process where a doctor or a physician is involved? I'm going to submit as written testimony after this hearing a letter from a doctor in the UK who was responsible for looking into some of this at both efficacy as well as safety. And her data that I'm quoting right now is from March of 21. Ivermectin's been around since 1992. Adverse reactions with 4 billion doses almost administered, or 3.7 billion doses, is 4,700. Total deaths attributed to this are 16. Now let's talk about aspirin. 1,430 deaths attributed to aspirin. Remdesivir, however you pronounce it, right? From 2020, it was introduced. 467 vaccines as of last year, 2,400. So my point is, there is a clear established safety where this drug is safe. It is used worldwide in a number of places. It is used as Senator Dr. Sherman would account for, right? This is to deal with parasites in your in your intestines, right? That's the primary use of this medication, has been for years. He and I have talked about a study that I'm going to reference at the end, the study that was commented in the New York Times, the one that was just recently published in the New England Journal of Medicine. But efficaciousness versus safety. This drug is a safe drug. It has been well established. You do have a chance to make it safer. I don't know whether we get to submit physical evidence in a hearing, because most of the time we're submitting written evidence, but I will pass this around and ask for it back. That is medication you can buy today. You can buy it from a pharmacy. Just doesn't happen to be in New Hampshire or the US. There's a lot of places online where someone can go buy ivermectin. Okay? What you're doing by passing this bill is putting someone in a position who can at least make sure two things are true. One, there's no contraindications of other medications they're using. Namely, the pharmacist can ask important questions and say, are you using anything that would be creating an adverse effect? The other thing is the quality of the medicine is likely to be higher. That's from India. Maybe great, maybe not be. I don't know. It's a lot harder to trace the medicine. Okay, you have an opportunity to make it safer. And I'm not talking about veterinarian grade versus pharmaceutical grade. I'm talking about straight pharmaceutical grade that can be purchased internationally easily, just like you would purchase on Amazon.com. Lastly, efficaciousness. I'm going to pass out two charts. The first chart highlights US versus India. Okay, number of active cases, number of deaths, things that we consider important. You'll see that in that chart, okay, the US has India has a much lower percentage of cases, not by half, not by a quarter, not by an eighth, but by a factor of 10 lower. Current cases, okay, the chart that's going around, you don't get this, you need to pass it, okay. Shows that there's 23,000 cases in the US currently going on per 100,000 people of coronavirus. India's 2,900, a full order of magnitude difference. So the question is why? And that's because they are administered effectively weekly, a pharmaceutical product to deal with parasites. And it does have a positive effect in terms of efficaciousness, okay, for preventing this disease. It interferes with the ACE2 receptors for the virus to take hold. And then lastly, regarding the study from the New England Journal of Medicine, okay, if you read their table that's in their study, okay, and we consider things that are important, hospitalizations, those on ivermectin had 79. Those taking the placebo had 95, a significant decrease. Death, 21 taking ivermectin, 24 taking placebo, more or less the same, but slightly better. Mechanical ventilation, 19 on ivermectin, 25 on the placebo. In every case, it was better or slightly better or significantly better than the placebo. I would encourage you guys to make this available over the counter, okay, for those who want to use it, and allow the pharmacist to be in the process or in the loop, okay, for making sure this medicine is administered correctly. With that, I'll close my testimony.
Seeing no questions, thank you very much.
Here's the left.
Yes? One question.
Thank you, JR. And we've talked about this. You used the word significantly better, but in fact, the study showed that there was no statistically significant improvement, correct?
No, it is. I would not say that's correct. In every area on that study, and we've gone over this, okay, other than those who are currently smoking, they had better results. Okay, if you look at the entire distribution of the curve, it crosses back over the center line. But if you look at this in every area, in every subcategory, okay, there was an enhanced performance and recovery time. The only exception to that was those who were currently smoking. Now, was it a magic bullet? I'm not saying ivermectin is a magic bullet. It has to do with how it's used. It has to do with when it's administered. It has to be administered at a right dose. There's a lot of things that go into a proper study to study ivermectin efficaciousness, okay? This study used the medicine at a lower than expected rate, okay? It discussed nothing about whether they used it with or without zinc. There's a whole other set of other things. But the point is, even in the study that the New York Times says it's horrible, it doesn't work at all, not an accurate quote, right? But their comment was, in the front page of the New York Times, was it doesn't work. Well, study shows that it does.
Thank you. Representative Leon signed up, so we're going to go to her right now, and then Mr. Berkey, and then our last witness on this bill, Paul Minahan.
Thank you, Good morning. Thank you, Mr. Chairman and members of the committee. For the record, I'm Representative Erica Leon, representing Rockingham 6, which is dairy. And I spent 12 years as the medical device analyst on Wall Street, trying to find where investors should put money in order to improve and save lives, evaluating early clinical signals, looking at the data that was available, and trying to make sure that they would put their money in a place that would benefit healthcare in our world. Doing that, I looked at a variety of different data. We relied a lot on Swedish registry data, which has some of those flaws that we hear about from the 160,000 people that pretty much walked in and said, yes, please, I would like some ivermectin. It's not high quality data, but it's data. And that data showed a strong signal. We have others that show a signal, and we also need to look at study design. It really matters when you give a treatment and a therapeutic. The high quality studies that were randomized, double-blind, placebo-controlled that we've heard about here in this country, unfortunately intervened too late. If we were to study Plavoxid, which is the one that has been developed for COVID, that one also needs to be done early, just as ivermectin only has a signal of efficacy when it's early. If you're too late for early intervention, you're too late for early intervention. But I think the question doesn't need to be about efficacy. The question needs to be about safety and the balance of safety and efficacy. When we were looking for both drug candidates and device candidates, we looked at that balance because if something is very safe, it doesn't need to be as efficacious as something that is very dangerous. We have quite a few very dangerous drugs that are in common use, but that's because the disease that they treat is worth that risk. Ivermectin is low risk. I would say that it's lower risk than aspirin, a drug that is very dangerous in pregnancy, but one that is over the counter, used commonly, and until more recent data showed, was something that we use to reduce heart attacks. With more information, it may not be as great as we knew, but I think that it's great that people have that ability and have been using aspirin off-label to decrease their cardiac risk. So what we look at here is a balance of safety and efficacy and realistically harm reduction. This body passed out a bill to study the, I don't remember, the opioid prevention places. I go by the abbreviation of the OPP. That's one where it would allow people to use illicit drugs in a safe place in order to reduce harm. I would say that ivermectin is far safer than illicit drugs. But I would say that people who want to get a drug, whether it's one that is FDA approved for some indications like ivermectin, or whether it's heroin, people will find a way. We have our citizens going to farm stores. We have our citizens ordering from India. And if some of the telemedicine bills happen, it may be a lot harder for them to get a consult and get a prescription with an out-of-state provider that they have not yet established a relationship with. So if that door closes and we don't open this one, then we're left with our citizens going to farm stores, going to India, mail order, driving down to Mexico, because I know people in California that drove down to Mexico to get ivermectin, and they will get it. What opportunity we have here is to provide a framework that already exists for more risky drugs so that those provider pharmacist pairs who believe that this should be available have the opportunity to evaluate, screen, and offer this early intervention, one that can't wait a week, one that needs to be done soon. Offer that to people so that we can reduce the harm of using farm store or Indian or Mexican ivermectin. I appreciate that this is stepping a bit out of where the legislature normally operates, but unfortunately, these are different times. We'll never have a claim of efficacy on ivermectin. It costs $2 billion in over a decade to bring a drug from discovery to full approval with the FDA. Over in Europe, they get drugs sooner. They say, is it safe enough? Well, there's a signal of efficacy, so let's let people figure it out. We're going to get more data, see how efficacious it is before the state pays for this therapy, but at least it's available for those who want to pay for it. That model has a lower cost overall, and it also allows people more of an option. And actually in Europe, people rely on their pharmacists a lot. I think that this is one of the places where we can learn from Europe, where we can learn from the rest of the world, and we can reduce the risk to our citizens of using medicine that they're obtaining outside of the normal channel and go to a pharmacist, especially because if we're able to get Plavoxid available early, which is a challenge, there's patients that won't be allowed to do that. Some of the cardiac medicines that interact with Plavoxid, it requires a month to stop taking amiodarone, or else Plavoxid is completely contraindicated because the harm is too high. Those patients should have an option. They can be told, I don't know if ivermectin is going to work, but I know that Plavoxid is a risk to you. If you'd like, you can try ivermectin, but if you're feeling ill after this, go to the emergency room just as you would. And lastly, as an early intervention, this is for the time when you show up at the doctor and they say, oh, it looks like you have COVID, you're not feeling well. If this, or this happens, come back. Because early options are still limited. This is only an early option. And I believe we owe our citizens an opportunity to get ivermectin manufactured in FDA-approved facilities. I'll take any questions.
Seeing none. Thank you
Thank
very
you.
much. All right, now Mr. Berkey. Okay, Ms. Minahan.
Good morning, Mr. Chairman, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations for the New Hampshire Hospital Association, representing all our hospitals. The Hospital Association is opposed to House Bill 1022. We have consulted with our hospital pharmacy directors and they have all expressed strong opposition to allowing this drug to be used in this manner. The chief medical officers and other clinical leaders have expressed similar concerns, and I won't repeat what has already been stated, but again, the FDA has not authorized or approved ivermectin for use in preventing or treating COVID in humans. So that is, I think, so fundamental to all of this discussion is that it's not that no one's saying that ivermectin is not a safe drug. They're saying it's not been proven to treat COVID. Currently available data do not show that ivermectin is effective, and clinical trials assessing ivermectin tablets for prevention or treatment are ongoing, as has been stated by Representative Knurk and others. There are many problems with this bill, and you have heard the concerns that have been expressed by the healthcare professionals today. If you have any other questions, we are happy to help connect you with any other clinicians that might be able to assist you. But the real concerns that we have with this bill have to do with the standing order that has also been outlined. There are only, my understanding is there are 3 medications under standing order in New Hampshire: naloxone, which is Narcan, oral contraceptives, and smoking cessation patches. The process to establish a standing order has historically been and should continue to be rigorous and involve all affected stakeholders and appropriate regulatory bodies. And I just outlined the process for oral contraceptives started with a bill in 2017, House Bill 287, to establish a commission, which I believe included, I counted about 19 members, and not just legislators. Those were stakeholders. They met through the summer of 2017. Then a result of that was a bill was filed, House Bill 1822, which outlined in detail the process to establish the standing order involving rulemaking from the Board of Pharmacy, and after the entire and appropriate process was completed was a standing order implemented. Also, the bill considered the impact on insurance coverage, which should be further concerned before this legislation is pursued. Another concern that has been raised recently is, and I believe warrants further consideration, there are no limitations on who could access the prescription. Specifically, minors could be able to access without parental consent. For these reasons, we are strongly opposed to this bill, and thank you for the opportunity to testify.
Senator Sherman.
Thank you, Paula. You may not know the answer to this question, but it's my understanding that ivermectin is pregnancy category group C, which means that it is not safe in pregnant women. Would this bill provide the protection against, would it require a pregnancy test prior to a pharmacist administering the ivermectin?
The way I read the bill, thank you for the question, Senator. The way I read the bill, no. There are no protections, just as the same issue that I just raised with minors being able to access it. That is the concern. This bill bypasses what I was just describing relative to the other standing orders that have been thoughtfully and rigorously considered here in the state. So it is that is another good concern. Thank you.
I just have two questions.
Sure.
The question I asked about 1466, is it your view that if 1466 passes, and I would note to the representatives on both sides of the issue, you all voted for it on a voice vote, would it give the kind of protections that a prescriber may feel is necessary to actually prescribe ivermectin?
The off-label bill, yes, I agree, it would.
All right. Secondly, there are 3 medications which have a standing order. Other than the contraceptive standing order, which was the result of a legislative commission, is it in Narcan or smoking cessation? Did the standing order come from the result of the Board of Medicine or the Board of Pharmacy, and did it require legislation?
So, good question. I feel like I should do more research on that question, and I will. I did more research on the oral
So could
contraceptives.
the Board of Medicine or the Board of Pharmacy recommend to the legislature a standing order after doing
Right.
more?
Yes. I believe the Narcan came out of the opioid task force that you chaired, and that was went on for, I don't know, 4 months, 5 months. And the result of that was a number of pieces of legislation, and I believe that was one of them. It's the Narcan standing order.
Okay, if you could get us the answer to that question.
I will.
that'd be great.
I will.
Okay.
Mr. Chair, just one real quick.
One. Any?
Do you support 1466?
We did not take a position on 1466, but to answer Senator Bradley's question, to address that bill, if it were to pass, would provide that protection necessary because it codifies the off-label drug use prescription process. So we are not opposed to it. Let's put it that way. I did not take a position, so I'm not going to say we support it at this point because we didn't take a position on the bill. You're welcome.
All right, thank you very much, Ms. Minahan. Seeing no other people signed up to speak on House Bill 1022, we will recess the hearing and open the, recess the hearing. We'll close the hearing on House Bill 1022, and you're going to shut off my microphone, and open the hearing on House Bill 1080. And again, we have a lot of people signed up to speak on this. Other than Representative Pearson, I'm going to ask people to try to stick to 2 minutes. Representative, good morning.
Thank you, Senator. I'll try to be brief because yesterday I scheduled 6 hours of hearings and we get out of here at 8:25, so I'll try to be brief.
And you exec House Bill 430, so thank you very much. John Williams texted me last night when I got home, so thank you.
Thank you, Mr. Chairman and Senators. When I was growing up in a Massachusetts mill town in the 1950s, the subject of rights of conscience was a topic much spoken of by politicians across the political spectrum and church leaders across the ecclesiastical spectrum. The failed Hungarian Revolution of 1956 and the ongoing imprisonment of Cardinal Mindszenty was on people's minds and lips. The phrase prisoners of conscience was often uttered. And stories were frequently told of the evil experiments doctors were forced to conduct in Germany during the 1930s against their conscience. The medical counseling and massage facility my wife and I established in Rockingham County 30 years ago is freestanding. It's not part of a medical combine of multiple practitioners. It was certainly not the local branch of a corporation. Unfortunately now, doctors finishing their residencies have little choice of starting a standalone practice where they can set their own policies because of the ever-growing complexity of regulations and of insurance. With hundreds of thousands of dollars of debt hanging over them, they join corporate medicine and they do what they're told. When a company says those patients need and will get 15 minutes of appointment, that's what they get, even if they need more. Too many family practice medicine physicians we know have left or are contemplating leaving medicine. As if that's not bad enough, we are learning that in some places it's not only the doctor's wisdom that's being challenged, so is his or her conscience. Thus, this bill. In the House Health, Human Services, and Elderly Affairs Committee, which I chair, we always try to make bad bills good and good bills better. We are fix-its. So my committee members wondered if I could expand the scope of this bill and do it in two different directions. First would be for conscience issues besides abortion. And secondly, would we include the conscience of other professionals, such as psychologists and counselors? I told them I'd like to keep the focus of this bill simple, but would happily work with any of them over the summer to come up with additional bills that parallel this one on conscience. The bill requires accommodation to individuals of matters of conscience in the area of abortion. Accommodation in the workplace is not unusual. Gentile workers often cover for their Jewish colleagues during the Jewish holy days, and Jewish workers reciprocate for Christians. Good companies do this sort of thing. Not all companies are good. The objection was raised that if this bill is signed into law, it would lower the number and quality of medical workers coming to New Hampshire. We only have to look at Massachusetts, where a bill became law and was on the books that was much stronger than the one you have before you. And yet, during that time, Massachusetts continued to draw good physicians, and the quality of medicine in Massachusetts was consistently ranked high. The objection was also raised that somebody might join a Planned Parenthood facility for the sole purpose of being a poison pill employee, one who draws a salary but is constantly deferring doing procedures. Well, first of all, Planned Parenthood regularly tells us that abortion is but a small portion of what they do. And secondly, if that's not true, I doubt anyone whose conscience objects to assisting in abortion would join a facility where abortion is a big part of what that facility would do. Over the decades, we've been told that violation of the civil rights of one is a violation of the civil rights of all. I would say the same is true for conscience. Growing up, I was told that we need to stand with and for others, even if their issue of conscience was not our own. To illustrate that, I close with a quote from Martin Niemöller, a Lutheran pastor in the 1930s and beyond in Germany. He said, "First, they came for the socialists, and I did not speak out because I was not a socialist. Then they came for the trade unionists, and I did not speak out because I was not a trade unionist. Then they came for the Jews, and I did not speak out because I was not a Jew. Then they came for me, and there was no one left to speak for me." So I would suggest that even if your particular conscience speaks to you in a way different than mine about the issue of abortion, please stand for the rights of conscience. Thank you, Mr. Chairman and senators.
Questions? Seeing, Senator Woodley.
Thank you, Mr. Chair. Thank you for taking my question, and thank you for all your work yesterday. I know it was a late night. You had a lot of complicated bills.
Thanks for coming.
I appreciate all the time that you gave all those bills. So the issues that you raised are, of course, so important, and I think, require a balance, right? And so I'm wondering why, are there instances in New Hampshire that you felt it was necessary to submit this bill when we have a New Hampshire law against discrimination, and the federal court, many times has spoken on this issue, sort of balancing the interests at play here. So I'm wondering if there are instances in New Hampshire why you thought this was necessary, despite sort of already protections in federal and state law.
Thank you for the question, Senator. As we are often told in the House Health and Human Services Committee, we see issues of this around the country, and we would like to get ahead of it here. So I have not heard personally of a medical person who has been subject to discrimination on this issue. It is happening elsewhere. It might happen here. I'd like to get ahead of it.
Seeing no further questions. Representative Torreson again. I'm sorry. Apparently he's not here. Representative Peter Torreson. Sorry.
There we go.
All right, now it's Knurk. And I have to go to Ways and Means, so I am going to let Senator Gray.
No problem. This will be quick. And actually, I'm glad you got that picture. Could you please send it to me? Because we do have a history of disagreeing on things, but liking each other very much. So again, for the record, Jerry Knurk, Carroll County District 3. I'm also a retired surgeon, and I'm here to speak in opposition to 1080. When this came to House HHSEA, the minority of the House HHSEA objected to the very narrow scope of conscientious objection in this bill. It's limited to abortion, it's limited to contraception, and to sterilization. Well, what about if a person objects to other treatments? For example, maybe they object to filling a prescription for Viagra for ED because they have a feeling that ED is a normal part of aging and we should not interfere with that natural history. Or if they object to participating in cosmetic surgery of some sort. Or to flip it over, placing it on the other side of the abortion debate, considering the Fetal Life Protection Act, shouldn't a provider be allowed to object to the demand that a woman be forced to carry a fetus with a fatal anomaly to term? Law doesn't allow him to do that. Though narrow in the scope of the objection, it is overly broad in its application, applying to anyone who works in healthcare. The receptionist could refuse to check you in for your appointment for a vasectomy, or to check you in to see your provider for your oral contraceptives. Or the biller might refuse to process your insurance claim. They're all covered under this. That's a problem. The bill also, I think, does open the door to harassment of facilities that provide reproductive health services, such as Planned Parenthood, and we did bring that up as Representative Pearson commented. A person could seek employment at such a facility and then refuse to do their job, and they would not be able to be dismissed, and the facility could be harassed by nuisance lawsuits. The comment was made, well, but they don't do that many abortions, but this covers contraception. When you take both of those together, that's a great deal of the work that is done in a reproductive health care facility. This bill also has the potential to lead to denial of care, especially in rural areas. There's not a pharmacy on every corner in Coas County like there is down in Manchester. So what if a pharmacist refuses to fill a prescription for the morning after pill, which must be available on a timely basis? They may have a hard time able to find a place where they could get that. So the bottom line is that I ask you to ITL this bill, given its narrow focus of allowing conscientious objection, but its broad applicability. And I'd be glad to take any questions. And I didn't give you a handout because this wasn't very technically complicated.
Madam Chairman?
Thank you. Thank you, Dr. Knirk. Don't we already have a code of ethics in the AMA and in the nursing associations that we're driven by in terms of accepting or refusing to care for a patient?
Yes, that is correct. The Code of Ethics does already cover this anyway, so it is redundant. And indeed, what it does, though, is it expands it to everybody, including, as I say, the office receptionist, the person who mops the floor afterward, the parking attendant out in the parking lot. All those people can object, even though they're not providing direct care.
Senator Whitley?
Thank you, Mr. Chair. Thanks for taking my question, Dr. Knirk. You also had a late night, so we appreciate you also. So we have heard in this committee a lot about how fragile our system in New Hampshire is for OBGYN care, that we have trouble attracting providers, that, you know, in horrible cases, women are having babies on the side of the road now, right? Because they just don't have access to the care close to their house. I mean, this is a real thing that's happening in New Hampshire. So I'm wondering if you could share your thoughts about how this bill would impact an already fragile system of care that we have in New Hampshire for OBGYN.
Thank you for the question. I think the bottom line is that people that are going into OBGYN know that the spectrum of the care that they will be giving will include, very commonly, reproductive health services. And if they're not interested in providing that, they probably would not go into that specialty. It is true that that much of medical care is corporate at this point in time, but I worked in a very large healthcare facility, Harvard Community Health Plan, that became Harvard Vanguard Medical Associates, and nobody ever told me once at all about what I could or could not do to treat a patient. That was left to us, and whether I would or would not treat a patient. I wouldn't deny people anyway. I would take care of them even if we had some disagreements. Now, having said that, I think that this could, I'm not sure if it would have much of an impact on our ability to draw or not draw, but it certainly would give us a really pretty weird reputation around the country as far as our reproductive health coverage if we pass this law when we really don't need it, since, as we've already said, you're covered in the AMA Code of Ethics anyway.
Senator Avard. Thank you, and thank you for your testimony, Doctor and Representative. In the previous testimony, it was pointed out that Massachusetts has a much more strident bill. And listening to potential New Hampshire being fragile, has their bill in Massachusetts diminished their care in any way because of that particular bill that they passed?
I do not know, because I'm not familiar with that. I would point out that most of Massachusetts, though, they use the example of pharmacies up in Coas County. There's not a whole lot of areas in Massachusetts that are that poorly served as Coas County.
Thank you, Dr. Dr. Yang from the Hampshire Medical.
Thank you very much.
Okay. I apologize for. All right.
New Hampshire Medical Society.
Thank you very much for allowing me to speak this morning. I am sitting here opposed to House Bill 1080.
You need to introduce yourself. State your name and where you're from.
Yeah, I am Dr. Og Young. I'm a retired obstetrician, gynecologist, having practiced 35 years in Concord. I'm a past president of the New Hampshire Medical Society, and I remain on the general council representing all obstetricians and gynecologists in the state of New Hampshire. I'm also an adjunct professor at the Dartmouth Geisel School of Medicine. And I'm here to oppose House Bill 1080. I'm going to be very brief. To put it very simply, this bill makes no sense. If it were to be made law, it would serve no purpose. Let me be clear. No physician, hospital, or other medical institution asks or forces a care provider to perform abortions, to do sterilization procedures, or even to prescribe contraception. I would like the sponsors to cite one example, just give us one example where a provider has been made to terminate a pregnancy, perform a sterilization procedure, or provide birth control against his or her moral or ethical convictions. I practiced OBGYN in a group of 5 physicians. 3 doctors in our group felt very strongly that women should have the choice as to when they have their children. And those 3 providers practiced abortion care. The other 2 physicians in our group didn't feel terminating a pregnancy was consistent with their faith, with their religion, and they did not provide abortion care. We remained respectful of each other, practicing together for many years. We never once asked that any of us change our convictions. The 3 physicians providing abortions never once asked the other 2 physicians to practice abortion care. Look, if there's no problem, we certainly do not need to create a solution. We don't need to have a new law that solves no problem, a problem that does not exist. House Bill 1080 makes no sense to me. As a law, it would serve no purpose.
Thank you. Questions? Senator Avard?
Thank you, and thank you for your testimony. In the previous testimony, it said that other states do mandate these mandates are happening in other states. My question is, has this type of legislation hurt Massachusetts medical procedures?
Have I ever heard of mandating abortion care?
Has others, according to previous testimony, other states allow these mandates to go forward according to previous testimony?
I'd like to see them.
Thank you.
Thank you very much, Doctor. The new list has a couple of state reps that haven't spoken yet on the list. You can get to the right one. Perez?
Good morning, members of the committee, and thank you for the opportunity to speak up this morning. My name is Maria Perez. I'm a state representative for District 23, Milford, New Hampshire, and I'm here to speak in opposition at 1080. As someone who is a survivor of sexual assault and incest, sexual assault, this bill would not help victims like myself. Would it make it harder for people like myself to get the day of the bill? It's already hard for my community because speaking about sexual assault, especially when it comes from a family member, is hard already. And it's harder for us to get what we need, just in case an accident happened after the assault. This bill will make it so hard for us to get the medical attention that we need. For that reason, I will ask the members of this committee to ITL this bill. Our community doesn't need, our victims don't need any more struggles. They don't need any more things to make it harder for them to get the help that they need. Please listen to the victims. Please listen to the women. We have enough bills try to cut our rights, our human rights, our reproductive rights. It's enough that my body was assaulted. If enough, I'm almost 50 years old, but the scars, they're always going to be there in my life. They're always going to be open scars. And when I see these kind of bills, it hurts. And it hurts to see others go through the same thing that I, almost 50 years, I'm still going through. Thank you so much for the opportunity to speak up this morning.
Thank you, Representative. Seeing no questions, Representative Leon.
Thank you, Mr. Chairman and members of the committee. I'll make this brief. Other states such as Massachusetts already have these protections. And while we've heard that there's no problem with this happening today, it sounds like this isn't going to, if nobody is forcing a provider to provide these services today, it's not going to impact anybody who's in our current healthcare system. The place it can impact is people considering a career in healthcare. If they know that they will not participate in these services, and they know that they can go into these fields, into obstetrics, into gynecology, into pharmacy, and have that right to not provide this care that is morally objectionable to them, one that they would change careers over. If they know that they have that protection and they won't be forced to do that, that can open up our healthcare pipeline so that we have more people entering the profession. I see this as opening that pipeline, having more people enter the system, because anybody who's already there, if they have a problem, they probably already quit. We're not talking about reducing who's in the system. We're talking about adding to it. And I'd like to have these protections so that more aspiring obstetricians, more aspiring pharmacists will enter knowing that their conscience is protected. Thank you.
Thank you, Representative. Seeing no questions, Representative Lloyd.
Hello.
Hi.
So I have with me a letter from other representatives who are opposed to this bill, and a copy of written testimony. So, thank you, Mr. Chair and members of the committee. My name is Cassandra Levesque. I represent Stratford 4 and Barrington. I'm here today to speak in opposition to HB 1080, particularly page 2, sections 3 and 5. As a patient, I am concerned because obstacles created by this bill would prevent myself and other patients from receiving our medicine in timely, convenient manner. Recently, after living in excruciating pain for many years, I was diagnosed with polycystic ovarian syndrome. I am currently taking birth control as a means to manage my symptoms. Without the prescribed medication, I would not be able to do my jobs as a legislator and as a volunteer for the Girl Scouts, or fully function in that is just unacceptable. If I went to my pharmacy and someone at the counter refused to give me my prescription and or refused to send the prescription to elsewhere, I would be left stranded and symptomatic. Birth control is not only used as a preventative, it is used to treat cancer, polycystic ovarian syndrome, premenstrual dysphoric disorder, dysmenorrhea, premenstrual syndrome, gliomas, ovarian cysts, bone mineral density, primary that one's going to be a little bit tricky, sorry, amenorrhea, migraines, and many, many more medical conditions. Being put on birth control is not taken lightly. The doctor and patient talk about what the options are thoroughly and how to take them and what the symptoms to watch out for. The doctor has a follow-up visit to see how you are adjusting to that birth control, and everything is carefully monitored. Some of these medications are time sensitive, and obstacles created by this bill would prevent patients from receiving their medications in a timely, convenient manner. Pharmacies are state-regulated businesses that supply medication to the general public, and they serve people of diverse backgrounds and faiths. They operate in the public world and should play by public rules. As such, pharmacies should take steps to protect the rights of their patients to access their medicine without delay or obstruction. But this bill makes no such provisions. I felt that it is very important to point out that the federal law protects the rights of healthcare workers and the Code of Law, the Church Amendments, the Public Health Service Act, the Weldon Amendment, and the Affordable Care Act. However, we must remember that when we protect the rights of one group, we cannot infringe on the rights of others. And I thank you for your time and ask you to ITL this bill.
Seeing no questions, thank you very much, Representative. And Dr. Dessard?
Good morning, and thank you for having me. My name is Dr. Lauren Lessard, and I'm an OBGYN physician here in Concord. I also serve as the vice chair for the New Hampshire section of the American College of OBGYNs, and I'm a faculty member for the, New Hampshire Dartmouth Family Medicine Residency, which helps to train a lot of our family medicine physicians in the state. I'm here today to express my grave concerns and register my opposition to House Bill 1080. As a physician, the most important aspect of what I do is to develop trust with my patients. Many of the things they discuss with me regarding their reproductive health and pregnancy are very sensitive and require openness and vulnerability. In return, they entrust me with care. This bill would serve as a roadblock in developing the trust that sometimes takes years to build. We spend many years being trained as trusted medical professionals, and legislation of our exam rooms only serves to create distrust and confusion to patients. This bill is broad and impacts all aspects of women's health care, with extensive implications to families in New Hampshire. It will touch all areas of healthcare, including private offices, public health clinics, pharmacies, hospitals, and emergency departments. Recently, I took care of a woman, already a mother to 3 children, who presented with an ectopic pregnancy, which is a pregnancy not within the uterus, and was actually implanted in her C-section scar. The condition is incredibly rare, but is also immediately life-threatening. Continuing this pregnancy would most certainly have caused her death. And this bill may have resulted in her not having a life-saving procedure had all the healthcare professionals in the emergency department, radiology, and the operating room not come together immediately to care for this woman. Any delay in her care or individuals choosing not to care for her would have had a very direct impact not only on this woman, but her family and community as well. In our state, we often have limitations on healthcare resources, and sometimes emergently transferring a patient is not an option. As an educator of the next generation of family physicians, I take pride in helping to train our residents in all aspects of women's healthcare. A trusted primary care physician is often the first person women turn to for any healthcare question, including contraception, infertility care, emergency contraception, and access to abortion services. While our physicians do not necessarily provide all of these services, it is important for them to be able to compassionately listen to their patients and to counsel them. This bill would interfere with a woman's ability to access services to make a truly informed and personal decision, or may lead them not to have these crucial discussions with their healthcare providers due to fear. A primary care physician may be the only available healthcare provider in a rural town, and having access to reproductive resources and knowing how to refer patients properly is a crucial skill. We often use contraceptive technology for non-contraceptive purposes, as we've already heard today. We use them for a variety of things, from controlling heavy menstrual bleeding to protecting against endometrial cancer. The nuances of how we use these medical tools may be impacted. A pharmacist's refusal to dispense a medication could have grave consequences, especially if a patient has limited transportation and resources, as many of our patients do. It is an honor and distinct privilege to be able to care for women throughout their entire life, to know their families and their communities. I urge you not to support this bill and to allow physicians and healthcare providers to continue to provide proper, thoughtful, and compassionate care. Thank you for your time.
Thank you. Seeing no questions, Planned Parenthood, Liz?
Good morning, honorable members of the Senate Health and Human Services Committee. My name is Liz Canada. I'm the Advocacy Manager of Planned Parenthood of Northern New England and Planned Parenthood New Hampshire Action Fund, and we oppose House Bill 1080. House Bill 1080 imposes a significant hardship on women, particularly patients in rural parts of New Hampshire. Because this bill is so broad, it allows almost anyone who works at a healthcare facility to refuse to participate in sexual and reproductive healthcare services, including abortion, sterilization, or even the distribution of contraception. For patients in rural areas of New Hampshire, this means potentially fewer providers, longer distances to travel, and delayed care on timely prescriptions. This legislation has far-reaching implications. For example, a woman with a doctor's appointment about birth control may not even be able to see her doctor if the receptionist refuses to process her paperwork based on a moral decision, maybe because the woman is unmarried. A pharmacist could refuse to refill a woman's prescription for birth control, regardless of whether it is prescribed for contraception or for any other medical reason. A cashier, citing their religious beliefs, could refuse to sell condoms. There's an important distinction between religious accommodations that do not harm third parties and accommodations that are considered conscience claims that do harm third parties. In the case of this bill, we're not talking about accommodations that allow a provider to meet his or her religious needs. An example of that type of accommodation might be addressing an employer's wardrobe policy and addressing that, which doesn't cause any harm to patients or the employer themselves. This bill, however, directly imposes hardship on a single group of people to allow for providers to make moral judgments about the healthcare needs of women. Under this bill, there is no obligation for a refusing provider to find someone else to deliver care to that woman. If a receptionist at a hospital turns away a woman facing pregnancy complications, this bill does not require that receptionist to give any additional information to the woman, not where to go, not to go find someone else to check her in. There is no requirement to do so in this bill. This bill does not include any protections at all for patients. House Bill 1080 explicitly protects the refusing provider from being transferred to another role, being demoted, being let go. So if that provider refuses in any way, they are then allowed to remain in that position. They cannot be transferred in any capacity. The employer is required to keep them there or face very steep financial penalties. So there are no protections for the employer, and there are no protections for the patient themselves. And to address a concern that was brought up earlier about Massachusetts and about other states, truly, this bill is not like existing laws in other states. This bill is incredibly broad, and it allows for all sorts of different employees to deny someone care, including information and referrals to someone else. We're talking about, again, denying admittance to a hospital. We're talking about denying selling condoms. We're talking about denying stocking the shelves in the store. So we are here again to ask you to vote inexpedient to legislate on House Bill 1080. Thank you.
Senator Sherman?
Thank you, and thank you for your testimony. You brought up something that I frankly had not thought about before, so I'd like to ask you a question about it. In practice of medicine in the state of New Hampshire and every state I've ever practiced in, you cannot abandon a patient. You can dismiss a patient, but you have to provide them with an alternative. In this bill, from what you're describing, not only can you abandon a patient, but you can refuse to treat a patient with no consequence and no requirement for providing an alternative to that patient. Is that your interpretation as well?
Yes, that is my understanding as well. And it's not just not providing them care, but again, not explaining why you're not providing them care. It's not finding someone else instead. And if the employer wants to, perhaps rightfully, change their role, switch their shift, whatever that might be, the employer is not allowed to do that. The employer faces financial penalties to even have that conversation.
Senator Whitley?
Thank you, Mr. Chair. I mean, I appreciate you raising these additional issues. I think, we have heard some testimony about how there are similar laws in other states, but what I'm hearing from you is that the breadth of this particular bill is different, and in particular, who it encompasses. So can you describe, we heard most of the testimony prior just on doctors and maybe nurses, but what you're saying is that this is an even broader definition of healthcare provider, and how does that compare to other states?
Yeah, the definition of healthcare provider in this bill, I don't have it directly in front of me, but it's about any single person involved in the process whatsoever of a patient trying to get contraception. So, the cashier, the pharmacist, the nurse, the receptionist, literally anyone along that path, processing paperwork behind the scenes, stocking shelves of condoms, like that, or anybody, that is who this bill protects along the way.
Thank you very much. Next on the list, ACLU, Frank.
Good morning, Mr. Chairman, members of the committee. Thank you so much for the opportunity to testify. My name is Frank Knack. I'm the policy director with the ACLU of New Hampshire, and we are here in opposition to HB 1080. Much of the material in the handout that you'll be receiving in a minute has already been covered in previous testimony. So I'll just focus on reiterate a few things that I think are important. One, Senator Sherman, as you just noted, the blanket application of this, including the denial of referrals, is something that is out of step with both the ethical requirements of the American College of Physicians, the American Medical Association, the American Nurses Association, American Academy of Physician Associates. If you look at their ethical, as you know, if you look at their ethical guidelines, there is a balance around the needs of the patient versus the ethical beliefs of the individual physician. And in this case, this bill, there is no balance. There is a one-sided approach that allows the medical provider, broadly defined to include anyone involved in the process, to deny services without any repercussions, and in fact protects them against both civil and criminal repercussions for any actions that they may have. I also want to note that I don't think it's been covered previously that both New Hampshire law and federal law already provide strong protections for religious exercise. And our law against discrimination, employers are required to accommodate religious exercise of their employees unless it's based upon a bona fide occupational qualification. And again, under federal law, employers are required to accommodate the religious exercise of their employees unless it is an undue hardship on the employer. So again, with ethical obligations already in place for medical providers, with protections already in place for religious exercise in federal and state law, this bill is unnecessary and has the potential to have severe repercussions, as you've heard from previous testimony. So thank you.
Senator Sherman?
Thank you for your testimony. Just to clarify, if a patient presented with a potentially life-threatening emergency, like was described with the ectopic and the C-section scar, which sounds incredibly painful, and it were up in the North Country, and we know that in those settings, you may have one ER provider, or maybe late night, and you may have only one person at the front desk. Could that person deny care or deny service to that patient with no accountability? I mean, in other words, they would be exempt from liability based on this law? For that
This
action?
law, that person, including, and if you look at the first footnote of my fact sheet, a broad laundry list of individuals would all be without accountability in that case. And I think that's the worst case scenario. You also have cases where a pharmacy, someone working in the checkout at a pharmacy could refuse to, sell someone condoms. So I think you have worst case scenario, and you also have the everyday cases that will happen to folks in the state.
Thank you.
Thank you very much.
Oh, sorry.
Senator Whitley.
Thank you, Mr. Chair. Thanks for taking my question. I'm hoping you can expand on one of the last things you said about there are already protections in state and federal law. And, as we all know, a discussion of those rights is important. No right is absolute. And so, both our statutes and our, and our look at these issues have to balance rights. And so I'm wondering if you can describe what's the balance of rights currently in federal and state law, and how does this law change that balance?
Definitely. So the balance of rights under state law right now is, quote, unless based upon a bona fide occupational qualification. And so their employers are required to allow the free exercise of their employees' beliefs unless it meets that threshold. Under federal law, employers are required to accommodate religious exercise unless, quote, undue hardship on the conduct of the employer's business. And so you have a very high threshold in both state and federal law currently. And so when you add that to the fact that the ethical obligations also have that balancing test of ensuring that the patients aren't harmed in the process in terms of a lack of referral, which this bill would not require. I think you can see clearly why this bill is extreme and would have, potentially devastating consequences to the state.
Follow up?
Briefly.
Thank you. So would you say that this bill throws off the balance already in existing law?
Yes, I think under this bill, there is no balance. It is a completely one-sided approach.
Next up is Holly Harris.
Thank you.
Holly? Lauren Camp? L-O-R-U-N, it looks like.
It's spelled a little differently, yeah.
Okay.
Hi, my name is Lauren Camp. I'm a resident of Durham, New Hampshire, and I'm here to strongly oppose House Bill 1080. I would ask you all to think of a young person who is capable of getting pregnant in your life. I'm sure that some of you do have children, and if not, that you have a young person who you are close with. I myself am a college student. I'm graduating next month with 2 majors and 2 minors, and I'm known to be studious, dedicated, and always open to a good debate. I've also been on birth control since I started college. The vast majority of my friends that can get pregnant are also on birth control. Birth control has helped me with a wide variety of medical issues, many of which we are ignored when we talk about restrictions that are put on birth control, despite the fact that more than 14% of birth control users rely on it solely for medical reasons. However, the majority of people who choose to be on birth control are on birth control for one reason, and that is because they do not want to become pregnant. Every couple of months, I walk into my pharmacy, like regular people do on a daily basis. I expect to pick up my birth control from my pharmacist. If they could simply refuse to do that, something that is a part of their job, because their beliefs are not congruent with mine, that could potentially deny thousands of people the much-needed medical care and pregnancy prevention that they need. It terrifies me to think that other people feel the right that they could decide what is best for me, when those decisions are supposed to be made by individuals after consulting their healthcare professionals. If this bill is passed, it creates a huge lack of trust between people and their providers by unnecessarily inserting personal beliefs into medical care. Ironically, I could leave the State House right now and go buy a pack of cigarettes, which are known to be detrimental to the human body. The cashier is not allowed to refuse my purchase, even if they have a strict personal objection to smoking, because that's simply just not how it works here. The idea that a pharmacist or a doctor could refuse reproductive care to me simply because they do not agree is a blatant denial of me being able to make my own choices. I asked you earlier to think of that young person in your life who could be pregnant. If you support this bill, I hope you again think of that young person in your life, but being denied birth control because their provider does not agree with them. Think of them worried about becoming pregnant when they cannot get birth control or emergency contraception. I hope that with that in mind, we can all see this bill for what it is, a bold overstepping of church and state that would deny basic rights and freedoms for all of us. For that reason, I strongly ask you to vote against this bill. Thank you.
Thank you. Next on the list is Autumn.
Hello, my name is Autumn Houle. I am from Candia, New Hampshire, and I am a lifelong resident of the state of New Hampshire. I'm here today to urge you to oppose House Bill 1080. As a student at the University of New Hampshire, my local pharmacy is the Rite Aid in downtown Durham, New Hampshire. This is where once a month I used to refill my prescription for birth control pills and pick them up, along with basic necessities like lip balm and shampoo. I received a prescription for birth control pills from a medical professional at Health and Wellness, where students at the University of New Hampshire go to receive medical care on campus. When I received this prescription, I felt comfortable, empowered, and safe because I knew that the medical professional who prescribed me the pills had my best interest at heart, which was to review all of my options for birth control with me and then allow me to make an informed decision for myself. As a first and second year student at the University of New Hampshire, I lived in a residence hall on campus and did not have access to a vehicle while on campus. For me, this meant that I had to access what was within walking distance from me. If the pharmacist at my local Rite Aid were to decide, based on their own personal or religious beliefs, that they no longer wanted to do the job that they were hired to do and are paid to do, and refill my prescription for effective and safe birth control pills, I would have had to go to great lengths to secure them or be forced to stop taking them altogether. Every person, including myself, deserves to receive reproductive health care in their own communities and without unnecessary barriers like travel and its associated costs. As a young woman capable of becoming pregnant from a long line of teenage mothers stuck in a cycle of generational poverty, it was important for me as an 18 and 19-year-old to take charge of my future and reproductive health. And at the time, the birth control pill was the best way for me to do that. It is not the place of a pharmacist to make choices about my future and my reproductive health for me, and this bill, if it passes, would allow that. I'm here today to urge you to consider some of the less obvious and unintended consequences of House Bill 1080. Please oppose this dangerous and broad bill and protect my right to individual choice and self-determination. Please oppose this bill and protect my right to access necessary reproductive health care when and where I need it. Thank you.
Any questions? Seeing none.
Thank you very much, Senator Gray. Holly Haynes. Good morning. How are you?
Good morning, Senator. Thank you for having me. Chairman Bradley and honorable members of the committee, thank you for allowing me to testify today on this bill. My name is Holly Haynes. I'm the former president of the New Hampshire Association for Justice, and I am a lawyer in Manchester at Abramson, Brown and Dugan, where I practice primarily medical malpractice. I have represented many women who have had emergent obstetrical complications requiring early termination of pregnancies, also many women who have had urgent gynecologic issues requiring sterilization for their health. As you know, the New Hampshire Association for Justice usually does not get involved in debates about abortion or right to life. Those are not issues that our constituents are focused on. We do, however, get involved in bills that involve immunities, and this bill, quite frankly, has a lot of shortcomings. It is extremely overbroad. It is very short-sighted, but the biggest shortcoming that we see is it provides blanket immunity to all healthcare providers who are involved in a decision about providing an abortion, termination of a pregnancy, sterilization of a woman, or contraception, and sterilization of a man as well, or contraception for a man. This bill is so broad that it would allow a pharmacy clerk to decline to sell condoms to a man if he wished to purchase them. The immunity itself, the problem with this is immunity begets public safety. It makes people act reasonably. And if you give immunity to people, it absolves them of the need to act reasonably. Physicians, healthcare providers would have no duty to get care in the case of an emergency for a woman. They would have no duty to follow the patient's wishes about their medical care. They would have no duty to get alternate care for a patient. I can foresee situations in the North Country in New Hampshire where there are limited, if any, medical providers for women. A woman with an obstetrical emergency, severe preeclampsia, maternal mirror syndrome, something that is putting her life at risk, goes to an emergency room at, say, Androscoggin Valley Hospital or Upper Connecticut Valley Hospital, and a provider there will not terminate her pregnancy to save her life. Under this bill, that provider would be completely immune from her husband or her children or her family bringing a claim for her death. And that just can't happen. People's right to conscience can't outweigh people's right to public safety. The principles of this bill, the people who are proponents of it, are focused on the sanctity of human life and the sacredness of human life. I would submit to you that most of these medical procedures, most of the time, are due to medical reasons other than family planning. There are medical emergencies. There are reasons that people require sterilization other than to prevent getting pregnant. There are reasons that people have contraception other than reasons to prevent pregnancy. Many women have bleeding problems, severe anemia because of excessive bleeding, and they use contraception for that purpose and not necessarily to prevent pregnancy. I think that this bill is just extremely overbroad, overreaching, and short-sighted with the people that it could potentially harm: women, families, and citizens of the state of New Hampshire. I'm happy to take questions.
Senator Rayvard, thank you for your testimony. I really appreciate it. I'm just curious, does this bill prevent any hospital or facility from hiring people with conscientious objection and those that do not? In other words, can they hire both?
I don't think this bill precludes them from hiring or not hiring anyone, from what I can see. But the problem with it is, if a facility has only conscientious objectors working there, people are going to be deprived of medical care, and people are going to die, and that can't be allowed to happen because of this bill.
Thank you.
Thank you, Mr. Chair. Thanks for bringing this issue. We had talked with a previous person who testified about the sort of balance of rights, and you bring a sort of different perspective to it in terms of, these blanket immunities for liability. And so, I think you clearly articulated how that could be problematic in terms of the rights of the patient versus the right of the person who's making the objection. But do you see any problems with this also depriving employers of that right also? So, for example, there was testimony that an employer couldn't sort of, put someone to a different shift if they were a conscientious objector, that this bill would potentially prohibit them from doing that. So do you see any problems with this bill robbing rights, regarding, the ability to seek, a civil claim, by employers? Maybe I'm not articulating that correctly.
Senator, I'm not sure if I do understand your question completely, but I don't read this bill as impacting employers or employees at all. It's just that employers can't fire people or discriminate against them if they are conscientious objectors. The problem is, if you have a facility with all conscientious objectors, if a woman calls to schedule an appointment to discuss family planning with her obstetrician and the scheduler on the phone doesn't want to let her do that, the scheduler can deny it under this bill. If a woman goes to an appointment and is checking in and someone doesn't want to check them in, this bill applies to absolutely every employee at that facility. It's not just the physicians. And it really could impact women and men at every point in their healthcare decisions.
Thank you.
Senator Sherman.
Thank you, Holly, for testifying. We've heard in earlier testimony, I don't think you'd gotten here yet, but we had heard that, Massachusetts does this and they have no problems. Do you know of any other state that has this broad is the right word, indemnification of employees?
I have not done that research, and I'm sorry, I can't speak to that. I don't know the answer to that.
Seeing no further questions, thank you very much.
Thank you, Senator.
Jason Hennessy. Morning.
Good morning. Thank you, Senator. So good morning, Senators, Honorable Chairman. My name is Jason Hennessy, and I'm the president of New Hampshire Right to Life, New Hampshire's largest New Hampshire's largest dedicated pro-life group. I'm also a resident of Amherst, New Hampshire, and I hold a PhD in computational sciences and statistics. On behalf of New Hampshire Right to Life's thousands of pro-life members, I want to encourage you to support HB 1080's right of conscience protections for healthcare practitioners, especially the abortion provisions. Many of you will have heard about the detestable allegations that the Chinese government forces Muslim Uyghurs to eat pork as part of the government's goal to re-educate the population into Han Chinese customs. For the many Christian healthcare practitioners who believe the Bible teaches clearly that the unborn are people and that killing people is wrong, being forced to assist in an abortion in any way is very similar. But you don't have to be a Christian to believe abortion is killing a child. Many other religions and most civilizations throughout history agree, reflected, for example, by the Hippocratic Oath's prohibition against it. If you want to keep ethical healthcare professionals in New Hampshire, and we don't want them to begin on the path of compromising their values, then the state needs to ensure that they are not forced to go against their consciences, whether by threat of termination or a lawsuit. Article 4 of the New Hampshire Constitution declares the right of conscience to be unalienable. Article 5 similarly guarantees religious freedoms. HB 1080 upholds both of these for healthcare practitioners. In terms of where New Hampshire is regarding the rest of the country, we're at a very extreme position. According to a research letter published in JAMA in 2019, 46 states have laws explicitly protecting the right of healthcare providers to refuse to participate in abortions.
Okay, thanks.
Of those remaining, one state exempts any procedure. So really there's 47 states. And so that leaves New Hampshire one of a group of only 3 states, which also includes Vermont and Colorado, that do not have conscience protections for people against abortions. So this is far from a strange reputation. I'll also add that article addressing the previous comment brought up by the previous speaker, the most common protection is against civil immunity, and that was in 37 different states. It's not in my written testimony because I didn't realize that was something someone wanted to bring up. So the question is, do we need a law? So you heard that we have federal laws that protect us as well as AMA. So I'll just bring up an example right next door in Vermont. In 2019, the University of Vermont Medical Center was issued a notice of violation by the federal HHS, which was followed up by a Department of Justice lawsuit. This was because a nurse was forced to take part in an abortion who had previously said she didn't want to. So HHS brought the suit, and And you would think that the story ends there. Great, the law's working the way it's supposed to work. But what happened was, as soon as the Biden administration took over, a few months later, the HHS and DOJ withdrew the lawsuit. And so New Hampshire needs protection because the we do not want our protections to be relying on federal protections, which are going to change depending on which way the wind is blowing at the federal level. New Hampshire needs to protect our own practitioners. And this is not just happening in other states. There's prima facie evidence, if you go to the Dartmouth-Hitchcock website, that OBGYN residents are required to refer for abortion. This is regardless of what they believe personally. So we don't need further evidence. We have the evidence right on their website, and I documented that in the testimony. And that's only based on what we've publicly documented. Residents have a strong disincentive to blow the whistle because it's very difficult to change residencies once you've started. Another point I'd like to raise is that we've heard a lot of testimony saying that there are physician shortages in New Hampshire. I can personally testify that I know of at least one physician, a medical school resident from Dartmouth, who refused to consider New Hampshire for her residency. When I asked her why, she said, oh, because they require you to do abortion as part of it, or at least observe. New Hampshire's largest healthcare provider is Dartmouth, which is a strong promoter of abortion. And so if we want to attract people from pro-life OBGYNs from other states, this is a protection we need to have in place. Otherwise, a lot of people won't even consider us. I also wanted to address a couple of other of the concerns I heard, especially and I wanted to contrast it with states that are actually very, very abortion friendly, because that'll just show you that this proposed law is actually very much in line with and not extreme at all. For example, New York and California both criminalize the violations. We're talking here about just civil immunities, but they actually take that and go further. Also point out, whether this applies to cleaners and receptionists and so on and so forth. I think it would be wrong to devalue the conscience rights of anyone who could be asked to participate in something against their conscience, regardless of their training, their education, or the prestige of their position. Denigrating the rights of those, the receptionists and the janitors is, I think, wrong. We should protect all the workers. And I'll point out that New York and Illinois both apply to anybody that works in a healthcare facility. The only one, there's a couple more, but the only other one I'll address is you've heard a lot about rural care. So I'll point out that California, Massachusetts, and New York all have large rural areas, and they still have these protections in place. And that's not even counting the rest of the country. So if this were an issue, you would expect those states to have reduced or removed these protections, but they haven't. So in summary, you heard that this is not an issue. The concerns that were raised were theoretical. I did not hear any actual examples of problems in other states. And there are 47 states to choose from. So there's plenty of opportunities. We have two real documented examples, one here in New Hampshire and next door in Vermont. And I'll also point out that this law is very mild compared to the rest of the country. Thank you, and thank you, Senators, for listening.
Senator Avard.
Thank you, Mr. Chair, and thank you for your testimony. With regards to, it seems as though there's a statement that this bill is overbroad, it's unbalanced. How does it compare to New York and Massachusetts bills? Is it grossly overbroad and unbalanced compared to theirs, or does it have very similar protections?
So the three laws, so I broke it down in my written testimony a little more. Almost all of the things that you heard were concerns are also concerns in at least one or more of those states. So for instance, New York and Illinois have the ability, don't restrict it to just doctors and nurses, for instance. It applies to anybody. So, Yeah, so I mean, if you just look at the most abortion-friendly states, we're in line with them. We're with this bill. I mean, there's obviously different states have different parts, but yeah, we're not extreme at all.
Bear with me.
Thank you, Mr. Chair. We've heard conflicting testimony to that, you know, Massachusetts was referenced a number of times, and how this bill is much, much broader, both in, you know, a number of things, but including how many people it encompasses. So I need to put that on the record that, you know, there is very conflicting testimony to that. So I'm wondering, you know, we have talked a lot about today the balance of interest, and I think that's an important conversation. And you know, I attend a congregational church. It's the United Church of Christ. So I'm wondering, and you talked about certain other religions, and I'm wondering how you think this bill impacts individuals of other faiths, such as mine, the United Church of Christ, or Unitarian Universalists, or the Reformed Judaism Church, you know, whose religion actually dictates that reproductive health, including abortion, is really essential to the well-being of women. So I'm wondering how this bill impacts those people.
Thank you, Senator, for your question. So, I mean, the bill protects the right, in my opinion, the bill protects the right of somebody who has a religious view from being forced to violate that view. Are you asserting that, you know, in certain religions there's like a positive view that you must do an abortion? Is that what you're saying?
No, that it is part of, yeah, it is the case that it is part in certain religions, such as my own, that abortion really is part of the healthcare panoply that is essential to a woman's well-being and their ability to direct their reproductive future. So, you know, the denial of an abortion would in fact be a violation of both my religion and, you know, a Universalist, Unitarian, someone who practices that, someone who practices Reformed Judaism. Wouldn't you agree?
Are you speaking from the perspective of the patient or from the provider?
Excuse me? Patient.
From the patient. So, I mean, the patient has New Hampshire's largest health provider is Dartmouth, which is gung-ho about providing abortion, as you've heard testimony. So, I mean, in New Hampshire, I don't know that would be an issue.
Thank you.
I just have one question. You heard the testimony of the prior witness, which I thought was very interesting. Would you be amenable to an amendment that took into account life-saving emergency situations?
Thank you for your question, Senator. I will point out that New York and Massachusetts have no emergency exceptions.
That was not my question.
So you're asking if I would be open to that?
Yes.
So New Hampshire, I believe New Hampshire Right to Life's position on that would be that we would prefer not to, because forcing somebody to violate their conscience would be is wrong.
Okay.
You asked.
Go ahead.
So am I correct in interpreting what your position is that in a select rural setting where there are no other options, the person working in that hospital has the right to deny life-saving care to a woman just because they believe that's right, as opposed to me as a physician where I have to provide an alternative to them or else it's abandonment?
Thank you for your question, Senator. So I've interacted with a lot of pro-life people because of the my involvement in this organization, and of the medical personnel, I don't know of anybody that would not perform a procedure to save the life of a mother, like an ectopic pregnancy or something like that.
So you would still, though, make it possible for that person to deny access to that woman because you would not be amenable to an amendment that would allow for that exception. Is that correct?
I guess, in my opinion, I did not read all of the other states. I read, but of the most liberal, the fact that two of them, New York and Massachusetts, have no emergency exception, probably means that it's not something that is necessary.
Which wasn't my question, but I get that you won't answer that question, so thank you.
Seeing no further questions, thank you very much.
Thank you.
Ms. Chester, welcome back.
Thank you, committee chair. Thank you, committee members. My name is Roxanne Chester. I'm from Bedford, New Hampshire. And I want to talk a little bit about this bill. I hear both sides of the situation. I am a woman who was, it was suggested that I go on to birth control at a very, very young age because of a medical situation. My pediatrician, because I couldn't go to an obstetrician, I was too young. That was a long time ago. Maybe it's changed now, but my pediatrician refused to put me on birth control. He was the only one that could have provided it. I instead went through excruciating treatments until I was old enough to start seeing an obstetrician. So I understand the concerns with regards to contraception. However, contraception is over the counter now. If your provider refuses. So it's a very different scenario. We're not asking anyone, we're not trying to take away anyone's rights, but that's what this whole bill is about. Not taking away our rights either as healthcare providers. In our state, because we are such a small state and we are close to some other states, without this bill, we have more and more and more really great healthcare providers going out of state for employment. In addition to that, as you heard testimony, Dartmouth-Hitchcock is the largest provider in our state. It has gotten to the point that it's almost impossible to find a provider that is pro-life, that is going to allow me to make my own choice for myself. So when they come forward and say, you know, it's discrimination against the woman, well, the bottom line is, without this bill, it is also discrimination. It's discrimination for the rights. It's a constitutional violation. It's my right to go to Catholic Medical Center if I choose to. But now that they're contracted with Dartmouth-Hitchcock, I now know that my money is indirectly being used for abortion. That bothers me. I'm not saying that I would want to take the choice away from anyone, a woman, or anyone else that is seeking any kind of this treatment. With regards to the concern that life-saving treatments may be denied, healthcare providers took an oath. And I truly believe that no healthcare provider, other than within the last 2 years, I have some concerns about what's gone on the last 2 years, but I truly believe that most healthcare providers, all healthcare providers actually, would never deny life-saving treatment because of their own ethic or moral, if they truly felt it was life-saving treatment. The problem is that that's been dictated as well, and that's where we start coming into what is appropriate. During the emergency orders in the state during the COVID-19 thing, I believe that we saw a lot of medical healthcare providers going against their own ethics and morals to keep their job. This bill would allow something like that not to happen anymore. Thank you.
Thank you very much. The last people signed up to provide information if their questions are John and Abby from the department.
Chairman Bradley, members of the Senate Health and Human Services Committee, thank you for allowing us an opportunity to come before your committee today. We are not taking a position on the bill, but as provided in our testimony before the House Health Policy Committee, and I spoke very briefly with the chair of the committee, Representative Mark Pearson, this morning, and I think that the committee should be okay with the requested amendment that we did request in the House. It just didn't make its way into the bill as an amendment. The bill currently is postured under the Department of Health and Human Services statute under a new chapter, Chapter 2126 EE. Our suggestion before the House Committee was to place it under, because it is in fact covering licensed entities under the Office of Professional Licensure and Certification, such as physicians and others, that it is more appropriately placed in a new chapter in the OPLC statute, which is RSA, which we would suggest and recommend would be RSA 332-M. Again, that's 332-M, simple amendment to the bill. And we can certainly follow up, Senator Bradley, with a email to your committee.
All right, questions of Mr. Williams or Ms. Rogers?
And for the record.
Oh, sorry, Abby Rogers, Legislative Liaison, DPHS.
We know. You're going to be on the hot seat in just 5 minutes. Okay, so if you can get that amendment to us, and what I would suggest, we're not going to take action on this bill today. Just speaking for myself at this point, I want to see that emergency life-saving situation clarified before we think about going forward with this bill. So I'm looking at you, Ms. Haynes, and I would urge you to work with the sponsor of the bill. I don't see Representative Pearson here, but Marissa knows how to contact him. If there's a way to bridge that gap, I would be most appreciative.
Thank you.
Okay. So I'm going to close the hearing on House Bill 1080. And we're going to take a break. But before we do that, we have 3 more hearings to go. I suspect that the hearing on 1379 will take some time. I would like to have completed the hearings, the 1488 and 1531, before we break for lunch. When we come back, I would hope we're going to be able to take action on a number of the bills from last week. I'm going to, except for the sponsors of the bill and the department, I'm going to start enforcing 2-minute rule from now on. Okay, well, I'll buy you lunch.
Part of my peanut butter jelly sandwich.
That's right.
All right, we'll be in recess
Had the wrong jelly.
for 3 minutes. We'll open the hearing on House Bill 1379 and recognize Representative Koflat. Good morning. Sorry to keep you waiting all day.
I heard representative.
Thought I said representative.
Oh, my fault. Thank you, Mr. Chairman, and thank you, members of the committee, for hearing my testimony. I will try to be as succinct as possible, understanding that you're under some considerable time pressure here. For the record, my name is Jim Kofalt, representative from Hillsborough County District 4, representing the towns of Wilton, Lineborough, Greenville, and Francistown. House Bill 1379 is intended to shift primary authority for establishing childhood immunization requirements back to the legislature from the Commissioner of Health and Human Services. Current statute under 141C20A authorizes the commissioner to make rules that specify childhood immunizations that will be required for children in New Hampshire. And currently there are 3 immunizations that are in rule but not in statute. Those are varicella or chickenpox, Haemophilus influenza type B or Hib, and hepatitis B. So while the commissioner, I think, has exercised very good judgment in not adding to that, in fact, New Hampshire's requirements are a substantially smaller subset than the CDC and ACIP schedule that is recommended nationwide. Nevertheless, the concern is that decisions of this gravity, that is, decisions to require an immunization or to require any particular medical intervention, ought to be taken very, very seriously, and in this case ought to rest with the legislature. Although the rulemaking process has some provision for public input, it really is not characterized by the same level of transparency and openness and public hearing that the legislative process enjoys. I want to emphasize that this is not an anti-vaccine bill. I recognize that vaccines have played a very important role in public health throughout our history. The polio vaccine saved countless people from very, very bad injuries and death. Over the past decades, we have had a number of vaccines that have shown very promising results in the United States and elsewhere. Nevertheless, it is a very serious decision whether or not to vaccinate one's child, and making that required ought to rest with the legislature. The committee, the Health and Human Services and Elderly Affairs Committee in the House, noted, well, let me first say that in its original form, this bill simply revoked rulemaking authority for the Commissioner of Health and Human Services with respect to specifying additional diseases against which children need to be immunized. During the House committee hearings, it was noted that this would have the effect of immediately eliminating the immunization requirements for those 3 that are in rules. It was not the intention of this bill to create that kind of abrupt disruption to the status quo. And so it was determined that we needed to amend the bill to allow for those rules to remain in effect through their expiration date in 2026. That would allow ample time for the legislature to undergo the full, open, and transparent hearing process to consider legislation adding those 3 to statute. In response to that, we drafted what I will refer to as the clean amendment. That did not prevail in the committee. It lost by a single vote. So there was an 11-10 vote that defeated the so-called clean amendment. I'm going to be handing out copies of that along with my testimony to the committee. But essentially all that does is it says that the existing rules that are in effect with respect to these 3 required immunizations would remain in effect through 2026 when they expire, and that would give the legislature ample time to act. There was another amendment introduced in committee, which was preferred by a 1-vote majority of the committee, and that was a bit more complicated. The second amendment added two provisions. First of all, well, arguably three. First of all, it added varicella to statute, making the varicella vaccine a permanent requirement. Second, it provided for a temporary mandate process wherein the Commissioner of Health and Human Services could require a vaccine for 20 months, and we chose 20 months because that would be the window of time, the largest window of time necessary for the legislature to take action with respect to adding something like that to statute. And it would require a 3/5 vote of the Health and Human Services Oversight Committee. It also, instead of simply saying that the existing requirements for Haemophilus type B and hepatitis B would continue to remain in effect until 2026, it instead moved those into statute and said they're in statute and they expire in 2026. So in some practical terms, that leaves us with the same result. However, I do have concerns about that as well. So let me address my three concerns with that, because I am going to request that the committee consider adopting the so-called Clean Amendment, which, as I said, originally lost by one vote. I would also point out that even those two of the members who voted against it remarked that they could live with either amendment. So I think that there's broad support for the bill in principle. I think that it is less confusing and less problematic if we have a clean amendment in place. But let me address my concerns with the way that this was amended first. Number one, it adds varicella to statute, and that in some respects violates the initial intent of the bill. The intent of the bill is that if we are going to require a medical intervention, and specifically childhood immunizations, that deserves a full, open, and transparent public hearing like any other legislation that we consider. This was added in an amendment at the last minute, and in fact, one of the members of our committee, who is an attorney, noted that, in her opinion, it was non-germane. The speaker did not rule it non-germane, he ruled it germane. Nevertheless, my concern is that adding varicella at the last minute, again, violates the intent of the intent of the bill as originally filed, which is to have that full, open, and transparent opportunity for the public to participate in that decision process. The second concern has to do with this 20-month requirement and the HHS Oversight Committee confirming a temporary requirement with a 3/5 vote. My concern there is that we're actually adding a sort of a novel role for the HHS Oversight Committee, one for which I don't believe it was originally created or intended. The third concern is perhaps a minor one, but if we move hepatitis B and Haemophilus B into statute, even with an expiration date, I think it creates a potential confusion and there's a lack of clear intent by the legislature that these ought to undergo the same level of scrutiny that anything else would undergo. In other words, it becomes very easy at some point down the road for someone simply to say, well, these are in here with an expiration date, let's just remove the expiration date and be done with it. So again, the bill as amended, I think, is a step forward. Nevertheless, I think that the bill with a clean amendment, which I will hand out momentarily, would be more in line with the original intent of the bill and would continue to have broad support as it did on the House Health and Human Services Committee with as I said, an 11 to 10 vote favoring the other amendment, but comments that some of those who voted for the prevailing amendment would be happy to live with the so-called clean amendment. So with that, I will take any questions.
Have you, representatives, shared that amendment with the department?
Yes, sir. The department has seen that amendment. The amendment that I'm handing out is is the original House amendment. So this, obviously hasn't been crafted as a Senate amendment to the current bill. This was a House amendment to the original bill. So this would give you an idea of what the bill would look like, sort of in its original clean form, with the one fix around preserving those three vaccines in rules through 2026.
Senator Sherman.
Thank you, Representative. When I started in the House in 2012, I was the only actively practicing physician in the House. And in the Department of Health and Human Services, you've got people whose whole career has been on determining safety, public health, all those kind of things. When I look at the three that you have here, hepatitis B is one of the diseases I treated when I was in active practice, has a risk of developing into cirrhosis and cancer, and is endemic in other parts of the country, parts of the world. And the vaccine has been a game changer in the United States. What is prompting you to change the current system to become much more cumbersome and potentially have people with no medical background overseeing a process that is highly based on medical expertise?
Well, it's not my intention that the decision would be made without substantial medical input. In fact, interestingly, the Commissioner of Health and Human Services is not required to have a medical background. Our current commissioner does. The bottom line is that, while I applaud the current commissioner, because we actually heard testimony from DHHS stating that there's no intention to implement a COVID-19 immunization requirement for children at this time because there's no consensus within the department. And I appreciated that answer, and I really value a commissioner who's going to operate with that kind of attention to collecting and respecting the opinion of medical professionals in her department. Nevertheless, I always like to look ahead to the what ifs, and the reality is that today, one person could make that decision, and without objection by a majority of GELCAR on statutory grounds, that would have the full force of law. The idea behind this bill is simply to say that decisions of that importance, decisions of that gravity ought to be ought to receive a wider hearing and ought to have a full opportunity for the people to be represented in that decision. And that would happen through the legislature.
Further question? Thank you very much, Representative.
Thank you.
Laura Condon. So I see, Laura, that you checked opposed to the bill. Red button. There you go.
Now I've got the red button. I did. And I have been talking and working with Representative Kofalt on this bill. And I think our goals are the same. But I think our concerns about what happened to this bill and the potential for this bill are different. For the record, I am Laura Condon from Bedford. I'm a volunteer director of advocacy with the National Vaccine Information Center. We're an educational resource organization. We assist people with obtaining information about vaccines and vaccination requirements and their rights under the law. This includes all people, healthcare workers, college students, parents of children, etc. We assist those who've been injured by vaccines, including those who've had an infant, child, or family member die following vaccination. I hear their tragic stories and assist them as best I can. To protect the public, we urge the appropriate filing of VAERS reports when serious adverse events occur following vaccination. The CDC counts on this public reporting system. This bill would remove the commissioner's authority requiring immunization requirements for children is very much needed legislation But I now, and I testified in favor, I now oppose it because of the bad amendment that was imposed. With the COVID pandemic and new vaccines and a CDC list of 72 doses vaccines recommended for children between birth and age 18, including COVID shots, here in New Hampshire, in fact, the DHHS commissioner has already mandated COVID shots for children in foster family households up to age 21 without exemption per rule HEC 446 that was approved by GELCAR on June 5th, 2020. I was there and I spoke against it. In fact, the requirement is all vaccines now recommended by ACIP, AAP, and the AAFP. And in fact, the COVID shot is now recommended by those organizations. So they may or may not be enforcing their requirement, but the requirement now exists. The time has come for a full legislature to resume the responsibility and oversight for vaccine requirements imposed on New Hampshire children. The bill, as originally written, was a good bill. It would not have removed any current vaccine requirements. The good amendment offers to preserve those in rule rather than statute, and to hand the authority back to the legislature where it once was for determining vaccine requirements. This would involve public notices, public hearings, testimony of doctors, scientists, other experts, parents, grandparents, teachers, government agencies, including the DHHS commissioner and others. Everyone is welcome to testify. It's a very open, transparent, and inclusive process. Our children deserve nothing less. As far as the 3 vaccines that were added to the statutory requirements, it's varicella, hepatitis B, and Haemophilus influenza. There's 9 doses total of those vaccines. There was 0 discussion relative to any need to impose these requirements in statute, and no discussion of the significant harm and failure that results from these vaccines. I was the one who raised the issue of this being a non-germane amendment. I had no opportunity to testify against that. Hepatitis B is an adult lifestyle illness spread mostly by, per the CDC, IV drug abusers and men who have sex with men. Why would 3 doses of that vaccine be required of New Hampshire babies starting on the day of birth when the rate of hepatitis B in infants and children in New Hampshire is 0 and has always been reported as 0 by DHHS? All pregnant women are tested and treated if they are hepatitis B positive. Yes, Senator Bradley, that birth dose of hepatitis B is still being required here in New Hampshire. When there is no disease in infants and children reported by DHHS, there's no ability to reach a case count less than that 0. Deaths from these shots is senseless and needless loss of infant life. To date, and you can look up in VAERS, to date, there have been 121 deaths reported of New Hampshire infants following vaccination with these 3 particular vaccines. They include babies like 15-month-old Ryan Johnson's from Nashua. I know Ryan's mom and dad. I've sat with his mom and dad. We've cried together. Not only have I read his VAERS report, which I have, but I've read his entire medical file on his death. There's also 2-month-old Hunter. Isn't he adorable? I have held and cried with his mother too. There's also Marcus. Here's his obituary. I've sat and cried with his mom. These parents often do not reach out to legislators like senators like yourself, but they do reach out to me as an advocate. So you may not be aware they exist. I assure you they do. This badly amended bill also attempts to create a process where vaccine requirements proposed by the DHH commissioner are taken out of the rulemaking process and would be approved by the HHS Oversight Committee. That is not a standing committee. It does not have requirements of public hearings, public notice, public testimony. It is not designed for the legislative process. So in fact, by putting in that committee, it would cut the public out entirely. The 20-month, rule is arbitrary, and, there's concern that that would get taken out. There was no need to add these vaccines to statute. The rules simply could have been preserved till their natural expiration as provided in the statute on rulemaking. So Representative Coldfelder has offered up a good amendment. and I urge you to consider that amendment. My concerns at this point in time, knowing the legislative process, that if you adopt that good amendment, I certainly encourage you to do so, and then I could support the bill. But the House needs to concur. You all understand the sausage-making process. I get concerned at that point in time that in the end result, this may not be a good bill. Otherwise, I would support it. I'm happy to take any questions that you may have.
Questions of Ms. Condon? Thank you, Laura.
Thank you very much, Senator, for the opportunity to speak.
Yep. Kate Fry, please. Followed by Pat Tilley.
Good morning, members of the committee. My name is Kate Fry. I'm the Vice President of Advocacy from New Futures. I'm here to testify opposed to House Bill 1379. We are a nonprofit, nonpartisan organization. We work to improve the health and wellness of all New Hampshire residents, and we work very extensively on public health issues across the Granite State. We support policies that decrease illnesses and diseases, including immunizations and programs to ensure equitable distribution. New Hampshire has an very strong vaccine program. We're fortunate that all children through the age of 18 can receive a vaccine at no cost. This is from combining general federal funds and contributions from insurance companies. The department purchases enough vaccine to provide every child in the state with all vaccines recommended in the Childhood Immunization Schedule by ACIP, approved by ACIP, the American Academy of Family Physicians, and they've approved the schedule. There's a nimble but careful process within the department regarding adding vaccines. Before the immunization program adds a new vaccine, there's a selection committee within the department. They review the input from providers, epidemiologists, and other stakeholders on the effectiveness. The department subsequently begins the administrative rule process, which does include a public hearing and legislative oversight from the Joint Committee on Administrative Rules. This bill repeals the department's rulemaking authority and reenacts it in a really confusing manner. Some vaccines are kept in rules, others are expire in statute. One can be added if there's approval by 3/5 of the legislative oversight. This method is not based in science, and it's not evidence-based policy. This bill would undermine the department's ability to provide protection from children from vaccine-preventable diseases. You have my written testimony. I won't go into detail, but very often childhood vaccinations, like other public health programs, are a victim of their own success. Because some of these diseases have been eradicated, you don't realize the effectiveness. But if we make it more difficult for the department to do what it needs to do to protect children through immunizations, you will begin to see these diseases again. So for these reasons, we ask the committee to vote inexpedient to legislate on HB 1379.
Questions of Ms. Fry? Okay, thank you very
Thank you.
much. Okay, Ms. Tilley, how are you this morning? And Abby?
Good morning, Chair. Good morning, members of the committee. My name is Patricia Tilley. I'm the Director of the Division of Public Health Services at the Department of Health and Human Services, and I have with me...
Hi, Abby Rogers, Legislative Liaison for the Division of Public Health Services.
Good morning. The department is opposed to HB 1379. As we have described throughout this session, immunization is considered one of the most important public health achievements of the last century. Vaccines have prevented millions of illnesses, disabilities, and deaths throughout the country. We no longer worry about our children becoming ill or perhaps even dying from a whole host of communicable diseases. However, vaccine coverage is not 100%, nor are vaccines 100% effective. Outbreaks can occur when an unvaccinated person becomes infected and introduces that disease into a community, especially within communities with low vaccination rates. The department has significant concerns about the public health impact of HB 1379. It unnecessarily places limits on the Commissioner of the Health and Human Services Authority to adopt new immunization requirements. It requires a supermajority of Health and Human Services oversight to add new vaccines for school and child care requirements. It then presents another opportunity for the legislature to vote on those items. Currently, RSA 141C provides the DHHS commissioner with the authority to adopt rules relative to which diseases require vaccination prior to school and child care entry. I appreciated that the sponsor noted that our current commissioner and all commissioners I've had the privilege to work with take this responsibility seriously, and it is not done by one person alone. These decisions are not made by one person. They are public and transparent and go through the legislative rulemaking process. Of the 17 recommended CDC vaccines, we only require vaccine for 7 diseases for school and child care, and an additional few for child care. It's HB 1379, if enacted, the department would need to obtain that 3/5 vote of the Legislative HHS Oversight Committee in order to adopt those rules. Additionally, 1379 permits new requirements to be brought to the committee only one time per communicable disease. This is problematic as the prevalence and severity of communicable diseases is not constant, and it would tie the hands of the department from acting in the best interest to protect public health. Again, you heard that the department, HB 1379 does not include Hep B and HIV in the list of diseases identified in this statute. The department believes that hepatitis B, E, and HIV should be included. Children should not be unnecessarily placed at risk of having a June 30th, 2026 expiration dates. Moving vaccines for diseases like chickenpox into statute also removes the department flexibility to respond to changes in vaccine as there are changes in vaccine and disease prevalence. The voice of parents and the public always has been an integral component of public health decision-making. The last time a new vaccine was added to our requirements was in 2003. And at that time, we received significant feedback from medical providers and the public around adding varicella or chickenpox to the requirements. The department believes that the current statute, which allows the commissioner to make changes through the administrative rule process, provides sufficient oversight and input requiring the department to seek that stakeholder feedback and legislative approval through JLCAR. Changes to the required vaccine for school and child care are just not taken lightly. As I noted, the last change was in 2003, and the one prior to that was in 1996. But if we've learned anything during COVID in the past 2 years, is we need to have flexibility to address emerging public health threats. The current system works, and it has significant opportunity for public input. The proposals in this bill are confusing and unnecessarily complex. The department takes this authority seriously, and it prioritizes feedback of medical providers and members of the public. We appreciate the efforts to not cause immediate disruptions to vaccine requirements, but we really urge the committee to find this bill inexpedient to legislate or add it to other study committees so that we can further take the opportunity for discussion about the finer points of these amendments brought by the House and to hear from more members of the community. Thank you.
Sorry, Mark.
Thank you, and real briefly, it was a big shock to me in the previous testimony that the commissioner doesn't have to have a medical background.
That is my understanding.
And quick follow-up, if I may, Mr. Chair, if then the commissioner doesn't have to have a requirement of a medical background, why would we deny the public more input via their representatives to tease out more information with the 3/5 vote?
That's great. That's a great question. Thank you, Senator. So while the commissioner herself or himself does not have a requirement for a medical background, the process of even getting to the commissioner in the first part will have some feedback. So we use our state epidemiologist who's in charge of our infectious diseases, Dr. Ben Chan, as we know right now. He would work with our infectious disease bureau and work with the medical provider community to come forward with a recommendation. They would bring a recommendation forward to the commissioner. The commissioner would then authorize whether that recommendation goes forward through the administrative rule process through JLCAR, which has that public input process built right into it in order to get that feedback. Again, the last time we did this was in 2003, and we brought people together to provide input early on. We would certainly do that moving forward, and probably even in a more robust way currently. Would we get that input on the front end, then go through the rules process and certainly take that input there, and then there's a legislative committee through JLCAR would have the final up and down vote.
Did you work with the House committee on the amendment that ended up being the House passed version?
Hi, Senator Bradley. I can speak to that. We opposed the bill in the House. So we did not. We suggested that we had some issues with the amendment coming over.
Could you say that again?
Sorry, we opposed the bill when it was in the House committee and accentuated our thoughts that the process as currently exists is sufficient because of the public input.
So from your perspective, the House passed version did not improve the bill?
Correct.
Okay.
Yes, I think if I can add, is actually more confusing, I think, to the process. And certainly the advocates in the House that were proponents of the bill spoke a lot about open and transparent process. And I think this just was more confusing, actually. And I think for someone that wanted to find out how that process works would have a harder time than the bill is introduced.
Okey doke. Seeing no questions. Thank you very much. I don't have anybody else signed up to speak on House Bill 1379, so I'm going to close the hearing on 1379.
Does that mean that we only have a smallpox vaccine?
Yeah.
I didn't ask the question.
Okay, so we've closed the former hearing, and now I'm going to open the hearing on House Bill 1488 and recognize the sponsor, or Representative Leon, to introduce it.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Erica Leon, representing Rockingham 6 in Derry, and I'm introducing this bill for Representative Prout as he needs to be at work today. This bill passed our committee and went on consent. It's because it is a very simple bill. During the hearing on this bill in our committee, the department did not oppose the bill, and it passed on consent. The bill enhances the existing non-discrimination section related to the immunization and vaccination registry. Currently, RSA 141C 20-FX requires that no healthcare provider shall discriminate in any way against a person solely because that person elects not to participate in the immunization registry. However, that's not complete. Paragraph 4 permits a larger list of entities to access the registry database. This includes non-healthcare entities such as schools and privately owned daycare agencies. These entities in current law could use their access to the database to gain knowledge of who opted out, and they are free to discriminate on the basis of that. Now, why would they do that? It's a lot easier for them if they can just go in and look at it and check. It makes it so that there's less paperwork. But we have a right to privacy in our Constitution, and this right to privacy shouldn't be a basis of discrimination. So because there's an incentive for these other groups that have access to the registry to perhaps discriminate by making things a little harder on these families that choose to protect their privacy, we have a really simple fix. Instead of saying no healthcare provider shall discriminate, it now would just say no healthcare provider or any other entity identified in paragraph 4 shall discriminate in any way. I think that this is a cleanup, although I know that language might be just as dangerous here as it is in the House to say it's a cleanup bill. But this just makes it clear that if you have access, you can't discriminate, and that's the only people we need to worry about. So I'm happy to answer any questions.
Are there questions? So you said this passed on consent. What was the vote in the HHS committee?
21-0.
21 to nothing.
Yes.
Wow. Miraculous.
I'd prefer if you can do the same
Thank you very much,
here.
Representative.
Thank you.
Ms. Condon, did you signed up? I don't know if you wish to speak or not. All right. Is there anybody else? No one else signed up? All right, we'll close the hearing on 1488. If we have 1 minute for Bradley to organize his papers. So I'm going to open the hearing on House Bill 1531 and recognize Representative Cornell or Representative Rice or Senator Whitley.
Happy to. Do you want me to go up there?
No, it's fine.
Okay. For the record, my name is Becky Whitley. I'm the senator for District 15, and I am bringing forth House Bill 1531. This bill originally was going to look to amend the Oversight Commission on Children's Services, and then it progressed, and now it just repeals 2 study commissions relative to children. The idea is that I'm currently working with Senator Carson who is the chair of the Oversight Commission, on another amendment. The idea was to sort of streamline the commissions, existing commissions on children, and put all the duties into the Oversight Commission. So there will be another amendment coming.
All right. Are there any questions of Senator Whitley as the sponsor of the bill? Senator Avard.
For this bill, there'll be an amendment?
There will be.
Okay.
Yeah, Senator Carson told me yesterday she was working on an amendment to this bill, so.
Right. And
I see Cam nodding his head. That means it's under control.
We have that amendment, but just last night, the committee got a letter from the new child advocate requesting another amendment. So, so I'm going to work with Senator Carson, who is the chair of the Oversight Commission, to see if that might be part of her amendment as well. I'll work on that with her.
Okay, just the deadline is.
Yeah. Okay.
It shouldn't have an
Has to be
FN.
exec next week.
Right, it does,
I'd like to do it tomorrow or today.
got it.
You know, this is what happens when you go away for a week and get stranded. You come back and want to be a tornado.
And we feel so bad for you stranded in Florida. Mr. Chair.
Florida.
No sympathy from committee members.
All right, is there anybody that wishes to testify on 1531? All right, I'm going to close the hearing. We're going to take a recess. What would you like? Half an hour, 45 minutes? Yeah, 5 o'clock.
Share my sandwich again. Little broccoli, maybe?
What would you prefer? Half an hour? Cam, any thoughts? All right, what time is your caucus?
To 3.
All right, why don't we say 1:45?
12:40.
I mean, 12:45.
12:30. We can do it.
You want to do 12:30? All right, we will be in recess till 12:30, and when we come back, we will start execing. Okay?
Leftover lunch.
That's actually fine for me.
That was so thoughtful. Look at the Yeah.
Motion to move in consent?
Second. Executive. Yes.
Did I just say consent?
Yeah.
All right.
Executive.
Okay.
Well,
It's been moved that we go into executive session. All in favor, say aye.
Aye.
So I just want to tell everybody, we have got 33 bills that we have to take action on. Not all today or tomorrow, but we're going to have long hearings next Wednesday. Short of coming in at 7 a.m. next Wednesday, we better make progress today and tomorrow, getting bills out, or else that's the alternative. And then it'll be Wednesday after caucuses if we don't finish, or Thursday after session. Okay, so I just want everybody to know, okay? All right, is there a motion to take up Representative Shapiro's bill, House Bill 103, the dental benefits?
Second.
All right, so it's been moved on to pass and it's been seconded. I have an amendment that Representative Shapiro brought to me. As you recall at the hearing, there was some discussion, it's Amendment 1332, that preventative services should not be subject to the $1,500 cap. That's lines 11 through 13. The word removable on line 4 is put in front of prosthodontic coverage. I think that's the only change there. And I'm not exactly sure what the appropriation change is. I think it's technical in nature. But this is an agreed upon amendment with Sherman and Edwards. John, do you want to say something on that? Why don't you just sit in the front row? Oh, well, sit there now, but stay in the front row.
Thank you. Thank you. Senator Bradley, thank you so much. And in the spirit of continuing to work together, as you may recall, the goal was to harmonize both Senate Bill 422 on the same subject matter, Senator Rosenwald's bill, and also Representative Shapiro's bill, which is HB 103. After the bill was heard in House Finance on Senate Bill 422, there was some additional tweaks that were made. So there's actually an updated amendment that Dr. Finney certainly could make you aware of. It's amendment number 1296S. 1296S.
Is that reflected in this amendment?
It's an earlier amendment number that you read, Senator, so I'm envisioning that it probably is not the most updated amendment to be working on off of.
All right, here's what I'm going to suggest. We'll be happy to entertain a floor amendment that's a technical fix. I think we should just adopt this now and get it done. Or I'm assuming it'll go to finance.
Understood, Senator Bradley. This is being
make
managed.
sure to get it to Ava so that we can do it as a floor amendment next week.
We will, Senator Bradley. Yes, thank you.
You're the best. Or in finance. All right, Senator Gray has moved Amendment 1332, seconded by Senator Avard. Any further discussion? All in favor of the amendment, say aye.
Aye.
Aye. Any opposed? Senator Avard moves ought to pass as amended, seconded by Senator Gray. Any discussion? All in favor, say aye. Aye.
Do we,
You know what, why don't we put this on the regular calendar, especially if we may be doing an amendment.
oh, right.
Senator Avard, you get the honors. I'm sure that Senator Sherman is going to speak, and so will Senator Rosen. We'll let Senator Avard take it out. All right, what is the situation? I'm just going down on my list of House Bill 230. We had talked about that. Is there an amendment coming?
Yes, Senator Perkins Quokka has an amendment, right? Okay, so we're waiting for OLS to get it back.
And has that amendment gone to the department?
I believe so.
230, the child care bill.
Senator Perkins Quokka has been working with DHHS on 230.
Yeah, go ahead.
All right, thank you, Senator Bradley and members of the committee. We did receive that amendment or a draft there too yesterday afternoon. We had,
Senator Perkins spoke up.
yes, yep, we received the email that directed someone to draft it for this amendment. However, we have not been able to fully vet this. It would significantly change something in how we are defining family childcare and family childcare group. While we are not opposed to the reasons why they wish to change it, it's just not something we've been able to fully investigate and determine the impacts across the department.
All right, I mean, we can exec that tomorrow, but you're gonna, if you could take a look at it.
I don't, we're not
Honestly,
going to have enough time to fully vet that. We have to look at state fire codes. We have to check with the state fire marshal's office. It talks about a residential community, which we have definitions in the statute for adult residential communities. We don't know what the impact's going to be. Well, we heard about this potentially coming up sometime in March, but we didn't think it was coming up this session. We thought this was an idea they were looking to explore. We would have some time to work on it for next session. We weren't planning on it for this session and haven't had the time to fully vet the information.
So, well,
No, the underlying bill is fine. This was an amendment.
Bill,
Correct.
Yes.
maybe Senator Perkins.
By a floor amendment or
Can
something.
work with them.
I think that works.
Are you good with that?
Yep, thank
All
you.
right. So Senator Whitley, you want to make a motion on?
Yeah. Well, you have an amendment. I move on to pass an underlying bill.
And I'll second.
And there should be an amendment.
1274?
1274.
Oh, I'm looking at the wrong bill. Sorry. I got it. I'm sure I have the wrong bill open. All right, Senator Whitley has moved 1274. This was the department's amendment. Okay, everybody ready to go? Any discussion? All in favor, say aye.
Senator Bradley, we have a motion, not a second.
We need a motion on the amendment.
Senator Sherman moves ought to pass on the amendment 1274. Thank you, Cam. Seconded by Senator Gray. All in favor of the amendment?
Aye.
Aye.
Any opposed? Perfect.
I move on to pass as amended.
Seconded by
Sherman.
Senator Sherman. All in favor, say aye.
Aye.
Aye. Any opposed? Are you comfortable with putting it on the consent calendar? You're going to talk to Senator Perkins.
Yeah, let's put it on consent and then we'll just pull it off if she can get an agreement.
All right.
I second the consent motion.
Okay. All in favor of consent, say aye.
Aye.
Thank you.
Okay, thank you.
All right.
Who's taking that out?
Senator Whitley will take that one out. I'm sort of jumping around trying to get the easy ones done before 1 o'clock on Senator Avard as somebody that's flown in from I don't know where, and we're going to have to take a break for half an hour. So can we jump to House Bill 1018, please? Which is Representative Goley's bill, the Board of Medical Imaging.
Second.
All in favor, say aye.
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 I'll take it out.
Senator Sherman has offered to take it out, and is there a motion to put it on consent?
Second.
All in favor, say aye.
Aye.
And Senator Sherman will take out House Bill 1018. Are you ready on the pork roast?
Yes.
Oh, no, like a lamb, I thought.
Leg of lamb,
Leg of lamb
the
bill,
leg of lamb bill,
1320.
1320. I move on to pass,
Second.
and there's an amendment that.
I believe it's 1404.
Right.
And the amendment talks about final disposition has not occurred within 48 hours. The body shall be embalmed or maintained at a frigid temperature.
Yes, so I really wish Senator Gray had been able to be there for this discussion. I'm sure it would have furthered his knowledge of decomposition. But This was a really great combined effort, and we convened all of the stakeholders, and this was agreed to by everybody, including the prime sponsors. And I want to thank Mr. Moran, who's back in the back there, for his flexibility as opposed to rigidity. Or
To move the amendment?
I want to make sure that Senator Sherman knows that I did have a conversation with the medical examiner's office, one of the assistants, about that. So I may be as you're well informed as he would hope I would be.
There we go. Well, thank you.
So
You can enlighten us at another
Move the
time.
amendment?
Senator Avard has moved Amendment 1404.
I'll second.
So it's been moved, it's been seconded. All in favor, say aye.
Aye.
Aye. Any opposed? Senator Sherman has moved ought to pass as amended. All in favor, say aye.
Aye. Consent?
Senator Avard has moved consent. All in favor, say aye. Aye.
I'll second that.
Any opposed?
I seconded his consent motion.
And I would love to take this out. I just don't want anybody to kill it.
You're going to be the embalmer. All right, Senator Sherman, we'll take this one out. All right, let's jump to 1507.
I move on to pass on this one.
Yep, this was another bill that had no opposition and it was voted easily out of the House. So it's been moved, ought to pass by Senator Whitley, seconded by Senator Avard.
There's an amendment.
Kirk amendment.
And so the Canuck amendment
On
was
1507?
an amendment, 0354, that the House intended to take up. And that's in the hearing report. But for some reason, even though they thought they had taken it up, it slipped through the cracks.
I move the amendment?
And so Senator,
I'll second.
Wait. I'm sorry. On 1507?
Yeah, it's 0354.
Right, I haven't seen it. Passed out at the hearing?
you need a copy?
Yeah. Okay, thank you.
All right, so Senator Sherman has moved, ought to pass on the amendment 0354, seconded by,
Canuck's name on this, is that okay?
yeah, it's fine.
All right.
Senator Avard has seconded the amendment. All in favor of the amendment, say aye.
Aye.
Any opposed?
Move on to pass as amended.
Senator Avard has moved ought to pass as
Second.
amended, seconded by Senator Whitley. All in favor, say aye.
Aye.
And is there a motion? Senator Gray has moved consent,
Second.
seconded by Senator Avard. All in favor, say aye.
Aye.
And Senator Gray gets the honors on this. All right. Let's take up 1659. This was Representative Abrami's bill.
Move on to pass?
Background checks. There was some discussion by the Department of Safety, but I think you can see in the hearing report, they were good to go. And the issues that were raised are issues that will need further discussion.
Move on to
Senator Avard has moved ought to pass.
A second.
Seconded by Senator Whitley. Any further discussion? All in favor, say aye.
Aye.
Any opposed?
Consent?
Senator Avard moves consent,
Second.
seconded by Senator Whitley. All in favor, say aye.
Aye.
And Senator Avard, have you gotten a consent blurb yet? This one's yours.
Thank you.
I'm spreading out the love here.
Love it.
All right, how much time do we have? We have 8 minutes.
Bill we heard today, 1488.
Yeah, I think that one's a pretty easy one.
Who's taking that out, Kevin?
Kevin has taken that one out.
Okay. Yep. Move on to pass on 1488.
Which one are we?
Hold on.
This is the bill that we just heard, Tom. It expands the
Prohibition
prohibition.
against discrimination based on individuals' election to participate in the state immunization. And you informed us that it came out of committee 21-0.
Yeah, I'm fine.
All right, so Senator Sherman moves on to pass.
Savard did that. You seconded it by Sherman.
I'll second.
All right. Havard moved on to pass. Sherman seconds.
Get it together,
Any further
Bradley.
discussion? All in favor, say aye.
Aye.
Aye. Senator Avard moves consent. All in favor, say aye.
Aye.
All right.
1488.
Who's, you want to write another blurb? Senator Avard gets this blurb. All right, we still have 7 minutes.
We're rolling.
Let's take up 1345.
1345.
This is one that has a Senator Whitley amendment that looked fine to me, but could you explain it?
Yes, so the amendment cleans up to make sure that the bill is compliant with HIPAA, basically. But I have to say, I still have a problem with the underlying bill. We heard from the social workers, NASW, New Futures, NAMI, Hospital Association, Dartmouth Hitchcock, all of whom had real concerns that this would interfere with therapy for teenagers. And I feel like we're at a time now in the middle of a children's mental health crisis. I'm just very hesitant to do anything to interrupt access to treatment for children.
I move on to pass on the bill.
Okay. Is there a second for ought to pass to take it up?
Second.
Seconded by Senator Gray. All right.
Before we go too far, line 6 in the amendment, it says agrees to a confidential communication between the minor and the healthcare provider. I'm okay with that, I guess. Is that another bill I was looking at, having the parent co-sign the agreement?
Yeah, that was one of the vaccine registry bills, wasn't it?
Or could be.
So do you need a motion on the amendment?
Already done.
I think Senator Whitley wants to move her amendment.
I think that we've already done that, right?
I thought we did on the underlying bill.
But we haven't, no, we just moved the underlying bill.
And I will say, there was, in addition to this, the idea that this could really interfere with, it would not allow children to be honest in therapy. I mean, the point of therapy is for them to get the treatment. And if we're interfering with that, then what's the point? So we did hear testimony about how there's an existing case, Berg v. Berg, that already covers this issue. So I don't think this bill is necessary.
I strongly believe that this bill is necessary and that we need to protect the parents' rights. They're the primary healthcare provider. They're the guardians, and I think we don't want to undermine their authority. And I strongly think that we should go forward with this. I agree to the amendment, but I'm even fine without it. So,
Senator Sherman.
Yeah, I am opposed to the bill unless there's a carve out for mental health therapy. It's just too sensitive. We had 51 kids in our emergency rooms last year. That's a really important delineation because the issues are so sensitive that the child is talking about. So if the amendment were a carve out for mental health therapy, I'd be able to probably vote for the bill, although I also have concerns about privacy of discussions about reproductive issues. So if we were to consider an amendment that would carve out mental health, I could support the underlying bill with the amendment, but even with this amendment, I can't be in support of it. But I think the amendment makes it better than non-amendment.
a compromise on the, in having the amendment that's been proposed, but any other carve-outs, I would be strongly opposed. I think no agency is, one of the things that we heard in testimonies, like I did ask the question, what happens if you get a bad counselor? Is that a possibility? Yes, it is. It's a possibility. How would the parent know? And what happens if there are multiple generations of children that are abused by a bad counselor? There's no way of knowing. So I think what my default is the rights of the parents to be the overseers and the guardians. So if a child gets hooked up with a bad counselor, unethical,
All right.
what's the recourse?
Here's what I'm going to suggest, since Senator Avard's meeting is about to start. That Senator Sherman, why don't you try drafting an amendment? If you have 3 votes for that amendment, we'll take it up tomorrow. Okay. All right, Kevin? You
Yep.
okay? All right.
Before, you need to withdraw the motion in the second.
All right.
we can move
So
on.
the motion, whoever made it, has been withdrawn,
That was, this is.
So withdrawn for now.
and we'll bring it back tomorrow. All right, we're going to be in recess till 1:30 and 1:30 sharp. We're coming out of executive session. All in favor, say aye.
Aye.
We'll be in recess again. Apologies till 1:30 sharp.
Who did you?
Oh.
Please.
All right, let me read the hearing report again. We'll do that. A motion has been to go into executive session. All in favor, say aye.
Aye.
Aye. And any opposed? Right, first one on my list is 583.
Move interim study?
This is the one that after today, I'm ready to be harvested.
It's just,
But you get what you pay for.
yeah.
All right, Senator Avard has moved interim study. Seconded by Senator Sherman. Is there any discussion? Okay, all in favor, say aye.
Aye.
Aye. Any opposed?
Consent?
It's been moved and seconded for consent. All in favor, say aye.
Aye.
All right, I will do the honors on this one. Okay, let's move to 1044. All right, this is the direct payment model.
Make a motion, ITL.
I second.
I'm sorry, which one?
1044. Could I convince you to make a motion of interim study?
Sure.
All right, so Senator Sherman withdraws his interim, ITL motion and substitutes interim
And
study.
I'll second that.
I just think this is a great bill, and I'm gonna vote against interim study. I would have made a motion to ought to pass. I just think.
Oh, this is the one that I had told Senator Avard I was gonna recognize him for an ought to pass motion
That's all right.
first. Do you mind if we do
I
that?
will withdraw my interim study.
Thank you very much. I'm sorry, Kevin.
I'm in favor of this bill, and I'm gonna move ought to pass. I think making a motion for it, I just like the idea of giving people more of an opportunity. I know that the terminology skimming is out there and all that. I know that there's concerns about horning in on areas where there's certificates of needs and stuff like that, but I just think people should have an option to pay cash and go direct to where they want. I just like the freedom that this bill offers individuals. I know there's opposition, but I like the idea of a decentralized option for individuals who want to pay cash. That's all.
Anyone else to discuss? Senator Sherman.
I think we have options. Yeah.
Turn your mic on.
Sorry, Cam. I think we have options. I think we allowed CON to sunset, so we don't have a certificate of need. I think there are some really creative and innovative projects already underway in the state. This one, however, really directly could directly draw people from other programming and leave us really in the lurch. So this is not CON, this is not overreach. And I'm all for innovative models, but this particular one I think is problematic. So I'm going to be voting interim study if we get there.
So that's not a second?
That's not a second.
For discussion purposes, I'll second the motion so that it actually gets a second.
Thank you.
And if I could speak.
Yep, please.
The healthcare, and I've talked about this to other people, you know, with various services being taken out of the hospital setting and put in other places. My wife, mammogram, okay? She doesn't go to the hospital, she goes to the mammogram place. If a lot of the surgery that was going on, you know, if it's specialty surgery, sometimes even though in Rochester it is in the hospital, and we're gonna put quotes around this, the butt doctors, you know, aren't necessarily associated with the hospital.
I call it the German exam.
Wow.
I put both.
Only technical terms in the Health and Human Services Committee, please.
But what I'm saying is that, you know, we're looking at this thing and we're saying, well, gee, you know, somebody that pays cash. And so, yes, I can support to pass it, and I can also support interim study because we need a consistent policy, okay? And if we're going to allow it for this group of people, why not people that pay cash? Why, you know, that their model for providing healthcare is cash.
And I'd even offer an amendment to offer to pay crypto, use crypto.
Doesn't help me, Kevin.
I know.
May I?
Senator Whitley.
Thank you. You know, I certainly support transparency. I think that just doing this small piece is problematic, though. I mean, we heard testimony about how this could actually drive up costs, decrease access. So while I support transparency, I just don't think this is the way to do it. So I can't support the bill.
Right, I would just say that somebody who's been around this issue for a long time, worked to repeal CON, then worked for the special licensure provisions, the study commission that we had on urgent care. I'm just continuing to be really concerned about the critical access hospitals, and I think they would potentially be the most impacted by this. I am the one at the table here that does represent some of the North Country, so sorry, Kevin, I can't support ought to pass. So anyone else for discussion? Okay, all in favor of the motion of ought to pass, say aye.
Aye.
So that's 2, and opposed, aye.
Aye.
3. Okay, Senator Sherman?
Interim study.
Senator Sherman has moved interim study. Is it seconded?
Second.
Thank you.
Could I make it a regular study then? How about a real study? I'll chair it. Is that a good compromise? Your call.
You know what I'd prefer to do is, aren't you on the Healthcare Oversight Committee, Chip?
Yes, I am on the HHS Oversight Committee.
What I'd recommend is that you go to the sponsor of the bill and ask them to take this issue before the HHS Oversight Committee and work it and potentially come back next year.
Okay.
All right? I'm trying to, save the commissions for you.
Gotcha.
Since you're volunteering. Sherman's going to be on every one of them with you.
I doubt that.
All right. The motion is interim study. Any further discussion? All in favor, say aye.
Aye.
Opposed? Senator Avard is opposed?
I'm opposed.
Okay, so it's 4-1. We'll go on the regular calendar.
Who's taking it out?
Senator Sherman gets this one. All right, 1003.
I move on to pass.
Is there a second?
Second.
Seconded by Senator Bray. I think the hearing testimony was that denial of care never happens. However, I don't see any harm in adding this to the patient's Bill of Rights. So that's my view on it. I believe it passed the House.
It was unanimous, wasn't it?
on a voice vote. Okay, any discussion on this one? All in favor, say aye.
Aye.
Any opposed?
Consent?
Second.
Senator Avard moves consent, seconded by Senator Sherman. All in favor, say aye.
Aye.
And who hasn't had many, Cam?
Don't believe.
Well, I tell you what, I'm giving this to Avard, and we'll let him off the hook on the next one.
Oh.
All right. House Bill 1035. I saw Representative Lang, it's his bill, he left.
I think he just stepped out in the hallway.
All right, you don't need to get him.
I'll motion ought to pass 1035.
All right, the motion on 1035 is ought to pass. There was no opposition, or at least no one testified in opposition. The House passed it on a voice vote with an amendment. All this does is drop the requirement for notarization if somebody is objecting to immunization based on religion. Okay, any discussion? All in favor of ought to pass?
We still need a second.
No, I think Senator Gray had seconded.
Oh, yeah.
All in favor of ought to pass?
Aye.
Aye.
And any opposed?
Consent?
Senator Avard moves consent. Is it seconded?
Yep.
Seconded by Senator Sherman. All in favor, say aye.
Aye.
All right, let's see, Senator Gray gets this one. Right, the next one on my list is 1099.
Move on.
All right, again, there was no one testified in opposition.
Mr. Chair,
Yes,
is this one that Director Littman might have an amendment on?
Can we hold off
John?
on this till tomorrow?
who had the amendment?
1099.
Littman. Yes.
Is Director
Unless
Littman
you
working on
have the
it?
amendment ready.
Did you say
1099.
It's,
You got the amendment?
Oh, no, we heard that Director Littman might have an amendment.
0491?
I don't think we have it yet.
And Senator Bradley, just respectfully, if you could hold on this for today, we will work to getting you the amendment to address the agency's concerns around CMS compliance. Thank you.
John, can I ask John one other?
yeah, sure.
I had asked Director Lippman if this would mean that private practices would not be able to continue to take Medicaid patients. And I don't think I've gotten an answer.
And I will follow up. I saw that
Okay.
email transaction as well, so I will follow up.
Okay, so you can text, call, write home. I'll be available.
Carrier pigeon.
All right, we will wait on that one. Cam, do we have the amendment on 1139? This is a amendment that came to me from both, I'm told, with the support of the Medical Society, optometrists have agreed on this. I had thought that this bill was going to go to interim study, but this amendment, Tom, did you get it?
Yep, got it.
Okay. Hopefully we'll resolve any issues that the ophthalmologists and the optometrists had. So, I hadn't seen it until now, but let me try to explain it. Mr. Berry is not here, but in essence, what he said is that if you've already had the measurement within 24 months, you're entitled to get it. And then after that period of time, if you have the measurement, the provider is entitled to charge you for it.
I move the amendment.
Second?
Sure.
All right, discussion.
Um,
Go ahead.
I was just going to say, I had a long discussion with one of the people who testified in favor of the bill, and what she wanted to make sure of was that if there were a measurement done, that the patients would have the availability, it would be available to the patient. And I spoke with Mr. Berry, and he reassured me that that would be the case with this amendment. So I'm holding him to that, but that's my understanding, is that her concern is met by this amendment.
Tom, Mr. Chair, do you want to do you want to read this amendment and just make sure it works for your constituent? We can circle back.
It'd be great. This is the first time I've seen it.
Right.
I know you want to knock these out, so.
You're lengthening your day tomorrow. Oh, yes, you are.
Well, I'm comfortable that I asked my question of Barry, and he said that it was.
Report shall be made available for upon request.
Yeah, so I think it's in here. I didn't say that.
Okay.
To hold back. I just wanted to make sure for the record that.
It's a good compromise.
All right, the next one on my list.
Did you want to go ahead, Deb, with this? I'm okay with going ahead.
Yeah.
Oh, you're okay?
I just wanted to make sure you were,
Make a motion to accept the amendment?
Yep, I did that.
So
I second it.
Senator Sherman has moved to accept the amendment.
Okay.
Hang on, let me,
Senator Avard seconds,
and it's Amendment 1500S, Cam. All right.
All, yeah.
Okay, well, see, I was already getting to the next bill. 'cause
I know, but we're back to.
We're back on
I don't
track.
hold you up, Senator.
No, well, see, that's the thing. I threatened to bring you in at 7 in the morning and suddenly it sharpens everybody's attention.
Yep, sir.
Okay, there's a motion on the floor to move Amendment 1500S. All in favor, say aye.
Aye.
Aye. Any opposed? All right, is there a motion of ought to pass as amended?
I'll move.
Senator Avard moves, Senator Gray seconds. All in favor, say aye.
Aye.
Aye. Any opposed? Is there a motion for consent?
second.
All right, it's moved and seconded. All in favor of consent, say aye.
Aye.
Aye. Senator Sherman, you get the honors.
Oh, thank you so much. I'm going to keep my mouth shut.
All right, the next one that I think we can do is 1241.
I move ought to pass.
Hold on a minute.
All right, so 1241 prohibits a school district from mandating a COVID-19 vaccination.
Mr. Chair?
Yes.
Okay, I can't support this bill. This is not even within the authority of school districts, so it feels wildly unnecessary. It would be DHHS, not school districts. And even if, DHHS did approve a mandate, school districts wouldn't even be able to comply with it under this bill. So I think it's unnecessary and inappropriate.
Should we add an amendment, Mr. Chair, to change it to the Department of Health and Human Services?
We did that on.
That's another bill, Senator. There's another bill on that
And you got
very
a study
issue.
out of it, and I think in order to protect your study bill, it would probably be a good idea to go a different route on. Curtis, you're done, you can leave. We accepted your bill and your amendment.
Thank you for stopping by, though.
Glad we had this talk. Yeah.
I would prefer an interim study since we have a study going on.
Right, so Senator Avard has moved on to pass. Has that been seconded? I haven't heard a second. All right, is there a different motion?
Move interim study.
Senator Whitley has moved interim study.
Second.
Discussion, Senator Sherman has seconded. All right, for better or worse, I'll have a discussion. We passed Senator Avard's bill as a study about how the department goes about the process of listing vaccines for school-age children and daycare centers. I've never heard of a school district mandating, because I don't believe they had the authority to mandate a COVID-19 vaccination. So this, while I understand what the sponsor's trying to do, that's never happened in New Hampshire. I think that interim study is the best course on this bill, primarily because we already have a study that we've sent to the House. And I think in order to protect that study, which you've volunteered to be on, we're better off interim studying this bill. Any further discussion? It's been moved. It's been seconded. All in favor of interim study, say aye.
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 Any opposed? Senator Avard's opposed.
Aye.
Opposed.
No, I'll go with aye.
On interim study? You sure?
Reluctantly, yeah.
You don't have to.
Okay, then no.
Right, Senator Avard does not vote for interim study, so Senator Whitley gets to take it out on the floor. It's 4-1. But I don't think Senator Avard's going to discuss it on the floor.
Might end up with another study.
Exactly. All right. Let's go toward the back of the pack and try 1487.
Yes, I vote ought to pass.
All right, I have an amendment that the department asked me to introduce, which is being passed around. It's amendment 1453. It adds, if a patient is a minor, the form shall require the signature of a healthcare provider. John, do you want to discuss that? And Abby.
Thanks, Chairman Bradley and members of the committee. Thank you for the amendment that you've requested. We do feel that it's important to retain the minor signature.
Could you speak up, Abby? I'm sorry.
Yes, sorry. Yes, thank you for the amendment. We do feel that retaining the minors, the parents and the minors, the physician's signature, if a minor is going to withdraw through the parent, their information in the registry is important. There was testimony in the House about a child that had appeared in the emergency room and there was no vaccination record, and there was testimony that there had to be change of care management and additional testing because of that. So we feel that, in the case that a parent doesn't retain that information, there would be an ability to have the healthcare provider know that that child's no longer in the registry. So thanks.
Okay, are there questions? Go ahead, Jim. Senator Gray.
This is the one that you've got the healthcare provider in there, the physician, but you don't have the parent in there. Okay, and if the parent isn't available, I think there's things you can do now. But I don't know why I'm taking the parent out.
Thank you for the question, Senator Gray. It's the way that it works is that the parent would have to request that the information be removed from the registry, but the form would have to be signed by the healthcare provider to remove the information as the parent is the guardian of the, guardian or parent of the minor child.
Just change the sentence at the end. That's the only thing we're adding.
Yeah, so for if the patient is a minor, we're just requiring that the healthcare provider sign that, but it has to be requested by a parent that the information be removed from the registry.
Yes,
Can I ask a question?
yes, I'm sorry.
Thank you, Mr. Chair. So at the hearing, I believe that the department testified in opposition. Does this amendment change your position overall on the bill?
I was not at the hearing, I can say that, but I know that we were opposed, had concerns with the bill because we would like to retain the signature. So yes, we would be very happy with this.
And just for clarification, the only thing that's being added to the bill is the last sentence. You'll see starting on line 9 of the amendment. The rest is on the bill as it came over from the House.
Okay, Senator Whitley seconds. All in favor of
Got more here.
the amendment, which is 1453? Aye, right? And the amendment passes 5-0. No one's opposed. All right, is there a motion of ought to pass as amended? All in favor of ought to pass as amended? I'm sorry, Cam?
Who seconded it?
Can I ask the department one question?
Yeah, sure. John, there's one more question.
John, I just have a question. One of the, in the discussion of the bill, during the bill, there was, and I circled this in 2 places, there's a mention in the bill of a form. And I don't think it requires statute, but one of the things that providers were concerned about is that people really won't know the ramifications of withdrawing from the vaccine registry. So that form, can that form, sort of like an informed consent, can it say, here's what you will not have available? And I don't mean it in a coercive way, just making sure that people are really informed before they withdraw from the registry so they know what access they're losing. Can that be in the form without statute?
Outside of the scope of the legislation that's before you, yes.
What was that, outside the scope of legislation, what?
Outside of the scope of the bill that's before you, Senator Brownlee, we already have the authority to add to that form appropriate language advising folks of information that could be helpful to them.
Right, so they're fully informed before they sign it, is all I'm getting at. Good, okay, thanks.
You two folks are the nicest people in the room. But I'm an old man and my hearing must be going badly, so please use the microphone.
Dumb question,
Senator Avard has a question.
and it might be dumb. Can the physician refuse to sign?
I think that if the parent is, if you have a physician for a child and the parent is asking to withdraw from the registry, I mean, it is, and it's currently an opt-out registry, that's the parent's decision. If I don't think that the physician can say no.
Okay.
They might advise against it, but if they felt that it was important for that child might be at risk. They may have had multiple doctors and they may counsel of the ramifications of removing the information, but they would not be able to deny that to the parent.
I was just looking at John's eyebrows as they were moving up and down, so I'm just kind of curious. Your thoughts, too? And not to this.
That truly was my thought process to figure which agency actually would have oversight over a physician that would refuse an action that was requested by a patient. It would not be Health and Human Services. That's what I was pondering over there. And I should have been looking up, more thinking, than down, trying to hide.
That's all right.
Watch your eyebrows.
Can I just make a comment?
Yep, go ahead.
So I think if the form is clear that the physician is signing as a witness, but not saying this is a good thing, that if a physician refused to sign, that would actually be grounds for a complaint.
Right, it would be the Board of Medicine.
It'd be OPLC, yeah.
Be careful.
They're not endorsing the withdrawal from
No,
the
sorry.
registry, they're just saying they're there,
Just
and they
signing
know.
off on it.
Right,
Okay,
Aye.
where are we, Cam?
yes.
So we have adopted the amendment 5-0. We have an ought to pass as amended, made and seconded.
All right. There is no further discussion, so all in favor of ought to pass as amended, say aye.
Aye.
Aye. And any opposed? Okay, is there a subsequent
Consent.
motion? Consent has been moved and seconded. All in favor, say aye.
Aye.
Aye. I guess Senator Gray is going to get the honors on that one.
You're not giving yourself much work.
All right, let's try 1495. I also have an amendment. John, please come back. I think this is more grammatical change.
I move on to pass.
Senator Avard moves ought to pass. This bill prohibits the state or any subdivisions from requiring a business to require a vaccine. Okay? Just so everybody knows what it is.
Thank you.
And I would note for the record while there were people that signed up to testify in opposition, while there were people that signed in opposed, no one testified in opposition. So John, can you walk us through the amendment?
Yes, it's very straightforward. By way of background, Representative Erica Leon worked in the House to get the underlying amendment that you'll see, which is 1013H. She worked with our agency to help us navigate the concerns that we had for New Hampshire Hospital as well as Glencliff Home around certification requirements for accreditation. And so therefore, our Chief Financial Officer, Joe Caristi, who did provide the background information, felt it was really important to clarify with a comma and an article speech A separating in that sentence. And it should read now as the amendment sets forth from the bill as 3 after the word facility, this would add a comma. That when federal compliance becomes an issue, that we have very clear law here separating both the facility from the provider. And if I haven't totally confused everybody, Senator Bradley, that is as simple as this amendment is.
Any questions on the amendment? Any further discussion on the amendment?
Yeah, can we take a quick break for a sec? Can we take a quick?
Sure.
Thank you.
Take a 2-minute recess.
Where are we, Kim? Which is,
All right, we have a motion on the amendment. It's been moved and it has been seconded. Is there any further discussion on the amendment? All right, all in favor of the amendment?
Aye.
Aye. Any opposed? All right.
Move on to pass as amended.
Senator Avard moves on to pass as amended. Is it seconded?
Second.
Seconded by Senator Gray. Is there discussion? Senator Sherman.
So fundamentally, we heard testimony during the bill, or we have received testimony that, and we know that this is not an issue right now. We've been through the worst pandemic that the state has seen probably since the early 1900s. And there was no use, discussion, or implementation of any kind of vaccine passports. There was no, so I don't think this is necessary. I don't think this has any meaningful implications, but what it does do is it, in section 3, even as amended, it does not address places like CCRCs, and so.
Like what?
continuing care.
Retirement centers, like in my area, we have Riverwoods, so.
Do they accept direct Medicaid or Medicare payments?
No.
No, many of the people that
So
are
the
in,
federal vaccine mandates don't apply to them at this
Correct.
point.
Right.
Okay.
but many of those, the vast majority are direct pay. So I would agree with Senator Sherman. I don't think this is necessary. I think it's reactive to a situation that hasn't even happened in New Hampshire. And why would we want to hamstring ourselves for future, whatever might come down the road? And then also, you know, we know that in particular, COVID impacted our elderly population the most. And so why would we, you know, prohibit certain things that we know might help them? And so I just feel like it's reactive. The language is also very confusing. I don't think it's a well-written, fully baked proposal. So I think we should hold on it. So I would, you know, if you would entertain an interim study, I think it needs more work.
I think just the fact that my colleague just said that we don't want to hamstring ourselves for future events or something to that nature belies, it goes to the nature of why we want this bill, because they're going to probably impose these things in the future. And the whole idea is to hamstring so that they don't impose these restrictions on businesses. So for that reason, I definitely support this bill as amended, with that beautiful compromise that we just put in. Thank you to the
Senator
department.
I don't see it as a compromise. I see it as a comma. And
nice comma.
The worst kind of bill is one that solves no problem and presents potential unintended consequences. And if you want to hamstring, remember, hamstring in a pandemic could be morbidity and mortality that was unintended that we're inflicting on people in the future. And we've been through, as I said, we've been through the worst pandemic the state has seen. And we're passing bills that are reactive about things that have never happened, and we have no clue. First, we have no reason to do this, but then we have no clue what the downstream effect is going to be. And my worry is that we may end up really regretting this if something happens in 10, 20 years where this took away our ability to protect people. And when we take away the ability to protect people with vaccines or any kind of medical intervention, although I don't anticipate this ever happening, people die. And that's what we try to avoid. We're trying to protect New Hampshire people. That's part of what we do. And so I'm going to oppose it.
One of the things that, if I may, Mr. Chair, is that I want to protect liberty so liberty doesn't die. And I think that's one of the concerns that we've been hearing from overwhelmingly. People don't want the government deciding how to, for us how to live. And I think this is protecting liberty. And it sends a signal that the default is liberty. So with that, I move on to pass as amended
All right, Senator Avard had already gotten on to pass as amended. Let's see if he has 3 votes, and then if he doesn't, we'll see if somebody else has 3 votes. Okay, any further discussion? Seeing none, all in favor of ought to pass as amended, say aye.
Aye.
Aye. And opposed? No. Okay, so it's 3-2. We'll let Senator Avard take this one out also. Okey-doke. How long do you folks have?
Until 3.
Until 3.
All right, you know what? I think we would be wise, whether we take any action on any other bills or not, to at least have a discussion on a couple of others.
Yeah. Could I limit it to 2, because I got to take care of my wife. 2 bills.
So when do you have to leave by?
20 minutes or so.
All right, okay, that's fine. 20 minutes, max. Okay, 1439. I have an amendment that tries to combine, and that's the visitation bill that I've worked with the Hospital Association on. It can be passed out now.
Thank you.
Everybody may want to read it, but if everybody's good to go on the say-so that the hospitals are okay with this, and I think there had been an amendment that was put forward in the House that was rejected, then they went with a committee amendment. This amendment works off of the committee amendment and makes changes. Steve, do you want to touch on it or not? All right. We can exec it today, or everybody can take the chance to read it, and we'll take it up tomorrow.
I can't even find my.
I
Tomorrow.
want to read it.
Okay, we'll take this one up tomorrow. Okay, the next one that's on my list of possibilities, depending on what we want to do with it, is one of the ones we heard this morning, 1379. This is the one that changes the department's rulemaking authority over vaccine policy. I had already, and I'll just start the discussion by saying this, I had already been leaning heavily toward interim study, but when the sponsors came in and said they didn't like the House passed version of the amendment, it only strengthened my view that interim study is the right way to go. Again, Senate Bill 288, Senator Avard's study is why I would have justified interim study, because that's what the study in your bill seeks to look at, how the department adopts new vaccines by the rules. I hadn't realized that it had been almost 20 years since a vaccine had been put forward by the department. So that was news to me. I think a study that your bill has is fine, and that's why, especially where the sponsors don't agree with the House passed version, makes all the sense in the world to me to interim study this bill.
But he did offer a clean amendment, and I think one of the things that did spark my interest was with regards to the fact that even the commissioner doesn't have to have a medical background, which to me says, well, then if he doesn't have to have, or she doesn't have to have a medical background, not everybody has to have a medical background. And basically the 3/5 votes for oversight just basically gives the people more control as to the decision making. And I understand 2003, it was the last time, but I just like a little bit more oversight in these agencies and for it to go before the people. GELCAR, I've sat on GELCAR for 2 terms, and I understand the process. And that rules do have the force and effect of law. And so you make a rule that has effect of law. I just think making it 3/5 votes for in the oversight, I like that idea. And I think the clean amendment that Representative Copal spoke of, I think that's what he had intended. And I don't know, I would lean more towards that. And I am a co-sponsor.
So the 3/5.
What's the amendment number that you're talking about?
0943H.
943, yeah. Sounds right.
The 3/5 is gone from there, isn't it?
Right. The 3/5 is taken out in the so-called clean amendment that the sponsor came in with. That's gone. It appears to me it's the original bill.
So
Senator Gray.
my analysis of this is we haven't changed really anything for 20 years, okay? This bill gives you 4 years to debate what the change was made, okay? And get it in statute and then go forward. So I think the amendment does the right thing. It gives you 4 years to debate it, okay? And get it in statute. You haven't changed it for 20 years. Thank you.
Okay, Senator Sherman.
I think 2 things. One is we heard pushback about putting diphtheria, mumps, pertussis, polio, myelitis, rubella, rubeola, and tetanus into actual statute from the department. And then, I mean, this feels to me like we are playing with this whole vaccine system by the seat of our pants. The House can't even decide how this should go. And we have a vehicle under the very capable hands of Senator Avard to actually take a look at this. And, you know, there was a comment that we don't need a hepatitis B vaccine because we're not seeing cases of hepatitis B in the state. And that kind of blew my socks off because I said, well, then why don't we get rid of all of them? Because we're not seeing smallpox in the state, right? We're not seeing polio in the state. So, and what it means is that it's working.
Mm-hmm.
That's what it means. So before we all get more confused by yet another clean amendment that was to replace the clean amendment that was not adopted by the House, I would agree completely with an interim study and letting Senator Avard take a look at this with his study committee.
So I know that the House is confused, but we're the Senate. We're not confused.
I'm
I'm sorry, Senator. I saw your hand up.
Thank
I
you.
apologize.
Also, you know, I think it's to take it back, House versus Senate, like we have 3 branches of government for a reason, and processes are in place through the executive branch and the legislative branch. We already have a process. There's a reason that we have JALCAR. There's a reason why we have fiscal, right? These committees are set up for these appropriate checks and balances that are working. And so I feel like these type of bills are so reactive to a problem that just doesn't exist. And we have these appropriate checks on the 3 branches of government. So again, why are we fixing a problem that doesn't exist?
All right, so
Do we have a motion?
is there a motion?
I move interim study.
I think Senator Avard wanted to move ought to pass.
Move ought to
Out of respect, I'm going to let him move ought to pass.
Move on to pass.
and Senator Gray seconds. We've had discussion. All in favor?
He wants to move the
I want to
amendment.
move the amendment
Oh,
0943H.
okay.
Second?
All in favor of that amendment, say aye.
Aye.
And opposed?
No.
I'm opposed. 3 against, 2 in favor. Now what? Do you want to move on to pass? Or should I recognize Senator Sherman?
I'll withdraw my second.
Well, the amendment failed.
Right. So I'll withdraw my second on the to pass motion.
Okay.
Which gives you a clean field now to do something.
All right. Senator Sherman moves interim study, seconded by Senator Whitley. All in favor of interim study, say aye.
Aye.
And opposed?
Nay.
All right. I'll take this one out. All right, so 1439, the amendment was distributed. I'd like to think we can exec that tomorrow. I'd like to think that we can exec 1466 tomorrow. There's some discussion about one word in that bill that has some importance. And I think, Cam, you can distribute the amendment I have on 1606. But while you're doing that, in the 2 minutes that we have left, John, you want to come up and talk about the fiscal note on 1606? You have the fiscal note. I probably have a hard copy of it. You want a hard copy?
Senator Bradley, yes, thank you. Speak
up.
Yes, the department, here we go. The department was requested to provide a fiscal note worksheet to the LBA. And the LBA produced this fiscal note based upon the information we had provided. So the bill, as it came to you from the House, does require certain significant systems changes that would be required for us to implement the legislation. A couple of ways to address it would be obviously an appropriation to the bill to cover the anticipated cost for the new system related, or to amend a bill to reduce those costs based upon the type of model that you would like for the department to put forward. As you'll see from the fiscal analysis, we initially estimated over $40 million. I realize that is a very sizable sum of money, and it's not lightly that we put a number like that out there, because we need to be very conservative in terms of the information we're providing to the legislature. As you'll see, we are splitting that up over state fiscal years 23, 24, 25. So it's for $10.5 million in terms of expenditures to the state that's anticipated. As you may recall, that information I had heard from the Director Tilley, that there are examples from other states that we're looking into to develop why we believe these costs are as they are. I believe the cost in California is somewhere, secondhand reported to me, around $70 million was what was mentioned. So we are certainly here to provide whatever other information we can for your committee, Senator Bradley, or get back to committee with anything that we're not able to address here today.
And let me ask you a question. If I read the fiscal note correctly, the current information system model that you have would allow an opt-in without major problems. The major problem becomes when you have to opt in on every vaccine.
That is certainly one of the factors. The bill, as it came over to you from the House, has a combination of opt-in, opt-out. That even makes it even more confusing from the standpoint of the fiscal cost for such a system.
So the amendment that I've just had distributed goes back to the original version of the bill. And it says every patient or guardian of a minor shall be given the opportunity to opt in to the registry. So I think if you could come back to us tomorrow and indicate if your current system, which is what I think I've been told, would allow that without, the prospect of a $45 million fiscal note. Okay?
We will do that, Senator. Thank you.
Can I?
Yep, Senator Sherman.
So I have talked with the House, and you'll notice that the bill came out, and John, you may have been there, 20-1 out of the House. And in my discussions with people on the House side, the reason it came out 20-1 is the providers and the department and others recognize that if this goes to a strict opt-in, as is anticipated with this amendment, that support would not have been 20-1. Nor will you have our support, because we know, and I'd love to hear the department's estimate, how much the participation would drop if you go to a strict opt-in, as we've seen in other states like Texas. So, God forbid, we follow this wave of decreasing the public health capacity of our state, and we go to an opt-in. If we do that, we know we're going to lose a significant portion, although we haven't had that estimate provided, but other states might give us a clue. And we decide 2 years from now to go back to an opt-out because we've lost so much information and so much capacity and so much ability to protect the people of New Hampshire should we have outbreaks of measles or anything covered by the registry. I just think this is a big deal, this amendment, going to a straight opt-in. I can't support it. And it does decimate, based on the history of other states, the quality of our registry. While I think an opt-out where you have, either as envisioned in the bill or as currently in place, where you have everybody being asked, do you want to opt in or opt out, which is what functionally happens right now because I've done it. I've given the vaccines at the booster clinics. Everybody has that option. But for this expense and for this loss of power of the registry, I can't support this as it currently is.
Just one point of clarification.
Wait a minute, I think that was a question, so John, go ahead.
And I certainly will, for Ms. Rogers to have her.
Speak up.
Yes. I will also ask Ms. Rogers if she would also please comment. I think we have to parse out the issues here. The issue that I was brought up here to the table to discuss was the fiscal impact related to the bill as it came over from the House. I think the ask of determining what that cost would be, we certainly will work to getting you that, Senator Bradley. Just on a quick observation, the amendment that Senator Bradley has offered would at least appear on its first face with one-time opt-in from a cost analysis would likely be much better than the projections we had on the bill as it came over from the House. That's one issue. On the other side of the issue, from a policy discussion around participation, I was involved with working with the legislature on the issue of standing up our IAS in the state. And I recall certain data showing that obviously that the opting out approach would generate a higher participation rate. There's only, to my knowledge, 2 states, Texas and the state of Montana, that have an opt-in process. But I do think that the ask of us today primarily is to reassess the fiscal analysis done on the bill based upon the amendment proffered by Senator Bradley.
Could we ask for one other part of that fiscal analysis?
See you tomorrow.
All right.
I'll ask you later. Yeah, I mean, I don't know that they can turn around a fiscal analysis by tomorrow, but
so
we can ask for it.
Currently, the bill is an opt-in, opt-out, right?
On every vaccine.
On every vaccine. So there's 2 questions. One is if you go to an opt-in, opt-out on only the first one, that only once per patient. And then the second one is if you do Senator Bradley's amendment. So the Sherman special would be halfway between the Bradley amendment and the bill, which would be keep it opt-in, opt-out, but only do it once. Can we price that out as well?
Senator Sherman, thank you. I just wanted to make a quick comment that the fiscal note was added to the amended version in the House, for the House bill. Currently, the $45 million over the 4-year period is for this current, it's not an opt-in, it's not an opt-out, but an opt. So if it were to go back to the opt-in, it would be probably, I don't have an exact figure, but Texas has estimated that, it would be $1 million less for the state of Texas, which is currently an opt-in, to move to an opt-out. But it would be nowhere near $45 million if you were to move either to an opt-in or an opt-out, but not an opt, which is currently as coming over from the House, if that makes sense.
Kind of.
Yeah, the system that we would have to implement from the vendor, which doesn't exist, it would be a bespoke system, like a special system to accommodate this opt, if you will.
I got it. Okay.
So it's either opt-in or opt-out, would be less expensive. Opt-in, probably $1 million more than currently we pay. But the expenses with the bill as amended right now from the House with the opt.
Senator Whitley.
Yeah, I mean, I think it's important when we're talking about this to talk about the policy. I mean, the fiscal pieces aside, we want a tool that's going to help us fight illness. We want a tool that's going to help us reach vulnerable populations. And if we are changing this in this way, again, we already have a system that's confidential, right? There haven't been any data breaches. It's secure. We're looking for problems that don't exist. We already know that this registry helps us reach those populations. So I really find it so hard to have these conversations when we know it's such a important tool that works and is secure and already protects people's privacy. So the policy is important, and I don't think we can not talk about that even when we're talking about the finances.
Okay. Anyone else on this? Thanks, John. Thank you, Abby. Try to get us that information tomorrow as best you can. Okay, so I think that's it for today. Before I entertain a motion to adjourn, I think the way we're noticed, I was trying to find the notice slip, but a half hour after session, is that correct? And it's, I believe, in Reps Hall.
So it is 10:30 or 15 minutes after the end of session in Representatives Hall.
All right, so either 10:30 or 15 minutes after session in Reps Hall.
And I would just ask that, because I'm going to be in judiciary and Senator Carson's
We will
also.
not exec any bills.
Thank you. And if you do, is what I was going to say, if you do want to exec bills, then if Cam can just call me and I can run over.
And that's what we'll do, because Kevin has energy, Jim has to be in energy. So Tom and I'll sit through the hearings, but I would appreciate trying to exec as many bills as possible, because the more we can get off the list tomorrow, the less likely I have to drag everybody back on
Yeah, and
Wednesday.
yeah, I
instead.
get that. Sharon's gonna just, Senator Carson's trying to do the same thing.
I get that. So. Cam, anything else? All right, is there a motion to come out of executive session? Senator Sherman moves, Senator Gray seconds. All in favor, say aye.
Aye.
Aye. We're adjourned till tomorrow. Thank you.